Well, good afternoon, everyone. I am Montgomery County Councilmember Gabe Albornoz, and it is a privilege and honor to be with everybody this afternoon. And I have the distinct honor and privilege of welcoming some of our newest members to our two new committees. I don't believe Public Safety has met since the new council has been sworn in, and I know HHS has not met. And so let me just welcome my colleagues on the HHS committee, and then my colleague and friend of the chair of our Public Safety Committee, Councilmember Katz, will introduce the colleagues of the Public Safety Committee. But I begin with Councilmember Lori Ann Sales. Councilmember Sales, as all of you know, served with distinction within the city of Gaithersburg and brings a wealth of knowledge within the health and human services field. And for context, each new member of the council that is not the chair of a committee has the opportunity to select a topic that they will serve as the lead for. And we are given the opportunity to carry over different issues from previous councils, or we're given the option of choosing an issue that we would like to pursue. Often these issues cross over not just within the specific committees that we serve, but cross over into other key areas. And Councilmember Sales has chosen to be the lead for helping to ensure we close the gap in the disparities of our public health system, which were exacerbated tragically throughout the pandemic. I look forward to working with her in that capacity and look forward to her leadership on that and so many more issues on this council. So welcome. Thank you so much, Councilmember Sales. And then next, I am privileged to recognize Councilmember Don Lutke, who's doing a twofer today. I, on the previous council, had the distinct honor of being the only council member that served on both the HHS and Public Safety Committee, and found that role to be invaluable, especially as we have gone through a historical moment in our country that demands that we as a community meet this moment. And the previous council has been working aggressively in that regard, and this council is very much looking forward to taking up the torch, which is why we are here today to get a briefing on our behavioral health system for Montgomery County and acknowledging that this is an all-hands-on-deck situation. 2 years ago, I had the opportunity to go on a police ride-along, and one of the cases that we responded to was a domestic violence case. In which one of the individuals was having a mental health episode and there was a gun involved in the incident. And I saw with my own two eyes just the pain that caused the immediate family, the challenges that presented to all of our public officials who were responding to that call. And that was unfortunately just a microcosm of what our first responders and our colleagues and friends of the Department of Health and Human Services deal with every day, every hour of every day. And so we are fortunate to have two departments that have been closely aligned, working with a number of other agencies, and we look forward to receiving the briefing this afternoon on their work and also find out about some best practices. And I do want to publicly acknowledge and thank Councilmember Lutke, who has chosen to be the lead for crisis response, which in this environment, given the world that we live in and the moments that have been so challenging for us as a nation, has never been more important than right now. Her experience at the state level is going to be invaluable, and she has already very much hit the ground running, helping the council on a variety of different issues. So I will now introduce my colleague and friend, the chairman of our Public Safety Committee, Councilmember Katz, to say a few words. And then as lead for this important topic, Councilmember Lutke will be helping to lead this discussion this afternoon. And so colleagues, if you'd like to speak after we turn it over formally to Councilmember Lutke, we want her to then facilitate the conversation from there. So thank you so much, Councilmember Lutke, and I turn it over to Councilmember Katz.
Thank you very much, Councilmember. I almost said Mr. President. Thank you very much, Councilmember Albornoz. And thank you to everyone who's here. And we're going to mention that as the chair of the HHS committee has mentioned, Kristen Mink is also a member of the Public Safety Committee, and we look forward to working with her and all of our continued work. And obviously, Councilmember Lutke has been mentioned several times, and we're going to be hearing from her very shortly as well. I did want to acknowledge the Sheriff, Max Wee, is here, and we thank him for working with us and continuing to work with us. I just came from a media briefing. The Council President Glass is still in that media briefing. But one of the things that I pointed out just a few moments ago was that public safety, and Councilmember Albornoz, as a former member of the Public Safety Committee, certainly knows this, that public safety realized years ago that we are not, we cannot and should not do things only as a public safety community. In public safety, just over the next month, today, obviously, we're having a joint committee meeting with Health and Human Services. Next week, we're having a Transportation and Environment joint committee on the Office of Legislative Oversight on the Dana Montgomery traffic violations. On February 13th, we're going to have just the Public Safety Committee meeting on police staffing, including the Emergency Communication Center, a true concern for all of us in public safety in general, but certainly for Montgomery County. Our staffing numbers are down. On February 27th, it's going to be 3 committees coming together. It's going to be Health and Human Services, the Education and Culture, and Public Safety to get a briefing on the opioid and fentanyl crisis with our youth. And then we also, though we haven't scheduled it yet, we're going to have a meeting on with the Education Committee on the community engagement officers, and we're going to have a briefing on March the 6th for use of force for the police. We are continuing to work with all departments. We are all very, very concerned that Montgomery County needs to remain a very safe place. We have had issues that we should not have had, but in general, our community is a very safe community, and it's because of the fine example of our very fine police department working with other departments. We are very proud of the men and women who work for the Montgomery County Police. And with that, I'm going to turn to the chair. With that, I'm not going to turn. I thought I was. I did think I was.
Thank you.
Councilmember Albornoz.
Thank you. My apologies. So I'd be remiss not to acknowledge that Dr. Raymond Kroll has recently announced his retirement.
Yes.
He served ably as the division chief for behavioral health for Montgomery County under the previous administration, and has served with distinction as the director of the Department of Health and Human Services for the last 4 years. He was the perfect person to help facilitate and put us on the right course for the topic of conversation we're going to be having this afternoon. So, Dr. Kroll, thank you for your service to our community, truly. And with that, yes, I now turn it over to Councilmember Lutke to chair this afternoon's briefing.
Thank you. I think this is mine. If it's not, somebody
Yes.
tell me.
Yes.
Okay. Well, thank you. I'm really happy to see actually so many friends and former colleagues in my prior life here in this room. It's been a pleasure to work on these issues. They're challenging issues, but it's something that I was so incredibly passionate about in my work at the state level. In that multidisciplinary environment, bringing together folks from the community, from our law enforcement communities, state, local, and federal, and our behavioral health communities together to solve problems that I wanted very much to make this a primary focus and to start off our work here with our public safety and HHS committees. So we have a number of folks here with us today. I want to first welcome our crisis intervention team from Anne Arundel County. We have with us today, well, let me back up. Let me tell you where we are here in Montgomery County. So we have been exploring what other counties have been doing to coordinate and improve response in our mental and behavioral health crisis delivery system. And while we do have some available sources here, it's no secret that we are undersourced right now and that everybody's trying to work towards building that up, but hiring clinicians has been challenging. We are also short-staffed in our police department. And as you heard, we'll have a separate briefing on that issue coming up shortly. Montgomery County has developed a response model that's in keeping with the Cahoots model. Some of you in this room, many of you already know that, but for those listening in, that had been used for 3 decades in Eugene, Oregon, and it stands for Crisis Assistance Helping Out on the Streets, and it is designed to reduce the level of interaction individuals in mental health crisis who are not so severe or not an immediate danger to themselves or others to get to stabilization and treatment without law enforcement intervention. But that is not for everyone, right? It requires that it is not a high-risk situation and that they are not an immediate danger to themselves or to others. And that model, the Cahoots model itself, was developed out of cross-collaboration, right? It was through discussions with the city government, their police department, fire and EMS response, mental health clinicians, and community members. And the irony of it was that the Whiteberg Clinic, which proposed these alternative models, they were all part of the 1960s countercultural movement, and that they were collaborating with law enforcement and mainstream agencies for the common good. So they were in Cahoots. So hence the acronym that was born from that. Now, to turn it over to our visitors here from Anne Arundel County, I have been privileged to work with Lieutenant Steve Thomas and Jen Corbin from the Anne Arundel County Behavioral Health Agency and Crisis Intervention Team as a part of my prior work at the state of Maryland. And in fact, our paths have crossed so many times that, frankly, I'm not entirely sure how I first met you. And they have been so involved, not just locally in Anne Arundel County, but in multiple state work groups to collaborate with other professionals to surface issues of concern, find solutions to incredibly challenging problems. And no matter how stressful, draining, or difficult these conversations are and the work in the field becomes, they get up and they go out and they do it again and again. And the focus of the work of the CIT in Anne Arundel County is truly restorative, therapeutic, community-based, and person-centered. The Anne Arundel County Crisis Intervention Team has received an award from Crisis Intervention Team International for their innovative and truly integrated approach to responding to high-risk situations requiring crisis intervention. I believe you all were formed in 2014, formally in the way that you are presently. And in the years that I've known them, they've handled everything from individual calls for high-risk crisis at individual residences to barricade situations, the Capitol Gazette shooting, and providing valuable critical incident stress management services for the public and for fellow first responders. And it's also important to note that they work closely with the judicial system. The state's attorney's office, the public defender's office, and other community providers to help find collaborative solutions to multifaceted mental and behavioral health challenges presented in our communities today. So with that, I welcome you to talk to us about your model in Anne Arundel County.
Hi, I'm Jen Corbin. I'm the director of the Anne Arundel County Crisis Response, and this is my partner who is
Steve Thomas. I'm a lieutenant with Anne Arundel County Police, but I'm assigned at Crisis Response. There's a lot of confusion because there are a lot of people that think I'm police at crisis, that we're that integrated into the crisis system.
And I think it's important to understand that our system, while we share it county to county in the state of Maryland, as well as outside of the state of Maryland, I've been to places like Cobb County right outside of Atlanta, and throughout the U.S., that the one thing that makes us unique in the state of Maryland is our mental health component is not within the health department. It is a nonprofit, quasi-government. We keep it that way specifically to be more robust. I want to say that up front because that is a difference between a lot of the other crisis systems in many different counties that run, is that we are set up how the original core services was meant to be set up, and then as slowly as they've become ingrained into the health department, we have stayed separate. That has been a decision from our police chief and our county exec to remain this way because it's beneficial to our county. So as I'm speaking, I just want to make that clarification because it does make it a little different in how we run versus Montgomery County. So I want to make that distinction up front. But when it comes down to the nuts and bolts of clinician, intervention, police departments, and focusing on what's best for our communities, doesn't matter where you come from, it's the way the work is done that is super important. And one of the things that I want to talk about today, because it would take too long to explain our whole robust system. There are 8 departments. We have mobile crisis. We have care coordination. We have hospital diversion, jail diversion, safe stations, which is just for the opioid epidemic. If we're focusing on our response with police involved, one of the things that I'm very passionate about, and I get a lot of criticism because I don't speak out enough about it, is when we talk about putting social workers in calls for service where police should be, we need to stop and think. What are we trying to do overall? Because we need to look at the whole system of response and what the individual needs are. And one of the things I always say, I'm a social worker. I'm not a police officer. I'm a social worker. I've not trained in police, is that when we respond to calls for service in the community, and we're talking about what we hear in the news and we hear across the United States about less calls where we send police and more calls where we send social work, we need to stop and think. Are we doing what's best and safe for the individual in crisis and also what's safe for the social worker? I don't think we've asked the social workers, do they want to be in these situations where they could be unsafe or lead to high risk without some kind of backup, without some kind of intervention. And because of that, that's why our model, to me, works the best. We were doing this, like we said, since 2014. I think where the key here is instead of putting a social worker with the police department, we did the mindset of putting police in with social work or in with counseling. So instead of sending someone over to the districts to respond with police or to respond to these calls, our chief allowed us to bring the officers over to sit in crisis. And where that commingling works is that officer gets to see day in and day out that mindset of the clinical intervention, everything from the phone call coming into the warm line that may be diverted from 911 into our warm line system that ends up as a community dispatch, down to calls for service where our mobile crisis is being dispatched on police radio. Mobile, our clinicians, our mobile crisis team, our CIT clinicians can all communicate with our officers so that the mindset as we dispatch out to a call is very similar versus putting a social worker into the police department and asking him to change an entire culture that's going to take years to do. If we break it down and we look at what we're going to do that's impactful now, my thought is that you're always putting the officer into the crisis system so that they can continue to build on the skills they learn through their crisis intervention training.
And when Jen started, we worked together in 2014, and actually I have to thank you because my beginning was in Montgomery County. Actually, I attended my CIT training was Montgomery County's in the spring of 2014. But she created a culture of helping. And what I mean by that is we treat our officers the way we expect them to treat the community. Our officers are part of the community and have the same mental health challenges with family members and themselves as the community has. So as we educate them, in 2015, we trained the entire department in mental health first aid. With that, we had a 21% reduction in use of force. Once we started our own CIT training in 2015, an important concept, and this is something following the CIT International model of there is no voluntold for training. It's giving the officers that have the passion to help, those officers that have an interest in trauma and mental health, the skills to be able to help the community. With that, we also, and it was under Jen's vision, that we also trained our officers in critical incident stress management to help with their own trauma and their own mental health for them and their family members. They coincide. It actually, the geek in me, it follows the Disney model of you take care of your employees the way you take care of the community. And I think that's what created our culture of helping. So we're at that point where road officers understand what's needed. There's times that actually Jen will say I'm more of a social worker than she is, even though I don't have the social work background. It's getting those officers, and I know you have it here working my conversations with Sergeant Matthews, that you have officers that have that caring attitude to say, I want to be the one to help that person. And we have done a lot of innovative things working with the judiciary. One of the number one things that stops a person with behavioral health from getting assistance is the criminal justice system. They're afraid to get assistance, the person with a challenge or their family for drug, substance abuse, as well as mental health treatment, because they may have an outstanding warrant and things like that. We've been able to fast track that with our judiciary, where we take people into the courthouse through the front door, right before a judge, get the warrant recalled, where we can take them right to treatment. And that's just a small example of the things that we've done, innovative, working with other community partners outside of the box.
And I think part of what we do is having the officer in a soft uniform, unmarked car, coming out to do visits with a clinician, is building that community policing back in. Like Lieutenant Thomas is saying, when we go in, half the time now, the person that is struggling with legal issues is asking for an officer to be with them. Can they pick me up? Can they take me to court? It becomes a piece where a lot of the conversation we hear it time and time again is, I've always ridden in handcuffs, and now I'm riding in the front seat with my CIT officer to get help. And so it's to change the culture, we have to work towards changing the culture. And pushing police out is not going to do that. Bringing them in, not only with training, but linking them with people who they can work with, like clinical or peers in recovery, peer support type model, is going to help with that. And I have to say, too, one of the things that we have to be cautious of as we look at putting more social workers out to do these calls for services, there's a depleting volume of social workers right now. Nobody is going to want to come out and do this field. I'm seeing it. We've had lots of conversations among the state of Maryland regarding the lack of social work or LCPCs to come out and work, because they can sit behind a screen at home now and do therapy and make a lot more money. So why would we want to go out in these risky situations, de-escalating a situation? So we have to be mindful that while we think this is a great idea to put clinicians out in the field, we can't forget about our officers, because many of our calls for service start with a call to 911. When we do a lot of community training with families, the first thing they say is, well, when my loved one's in crisis, I'm calling 911. So you're still going to get that police response. So how can we make that police response appropriate and safe for everyone? And that comes down to looking at comparing and making that whole. And so I think that's a big piece to our system. One thing I will share is that Montgomery County has a lot of these pieces in place. We've had 2 visits where representatives from Montgomery County have come out, and we've walked and we've talked. We've shared a lot of what we do. I think there's really good building blocks here to do it. It's how to continue that path, and in any way that Anne Arundel can be helpful in that piece, we are willing to do that, because look, we all cross jurisdictions with clients that we serve and individuals that we serve. So we want to be good partners and share that piece. And I know you're going to hear later, I've done some work with individuals on comparing our models to get there. So hopefully we can help you get there.
So do any of my colleagues have questions? Yep.
I do. First off, thank you very, very much for being here. And years ago, I actually heard a presentation from the Maryland Municipal League. I'm going back a few years ago, and on your system. And I guess Anne Arundel County is about half the size of Montgomery County. We have a little over 1.1 million, and I think you're about that 500,000 or close. So what is your staffing size for this unit, for the
I think it's unique because we share a lot. So the officers, like I said, are in-house in crisis response. And so one of the things we do is we have 8 officers, a sergeant, and a lieutenant. And we have 5 clinicians on the CIT side. But remember, I'm also running like 6 mobile teams or 5, depending on what shift we're talking about, that can utilize the officer. So if we get dispatched on radio, and we can also have mobile come over and grab one of those officers to go with them on a call if we feel we want to relieve patrol from that call. We are probably about half the size. That is actually correct. The size of the crisis system is about, on clinical side, now that's your warm line operators who aren't necessarily licensed clinicians, but between all of our systems, we are at about 80 or so employees, but remember that most of them are part-time or what we call continuous part-time. Finding full-time people that want to do shift work is tough. So we actually get a lot of people who work with the health department during the day and work with us in the evening because they want to keep their clinical skills up. So I would say over half of our employees are more of the part-time or work a couple of shifts a month.
But also to add on the sworn side, we have 216 officers who were voluntarily attended CIT training. With that, we fill a lot of open positions in the sworn side of CIT with officers from patrol, which is nice because they're in patrol in other areas in the county where they can come in, work with clinicians, work firsthand throughout the crisis system so that when they are on that initial call, they have that familiarity and know the appropriate people to call for help. We have, right or wrong, I set our minimum staffing at 4 officers Monday through Friday in the day work, 3 in the evening, and then we have 2 day work, 2 in the evenings on Saturday and Sunday. And a lot of time, the Saturday and Sunday is mostly overtime, and depending on leave and things like that, we generally have 1 or 2 officers on overtime throughout the week.
Do you respond in Annapolis City as well?
Yes.
You do?
Now, they have a sergeant that's actually assigned at our office. So Sergeant Vaden she does a lot of things in Annapolis City, but we will respond and be primary on follow-up and things in Annapolis City.
And I would have to say it took a while, but Annapolis to get on board to understand the importance of having an officer up at our office. It took probably 3 years and several meetings for them to say, why should we send up there? Why aren't you sending a clinician down to us? I said, you get more resource if she's up there. In fact, today they dispatched for a call. And it was great because she would have missed out on that call had she not been housed with us because it came through the warm line. And when we came over to dispatch, she's like, that's me, I'll go. Because otherwise we would have grabbed a county officer and gone to that call. So the follow-up in the community is better when you have that officer there responding that works in that district.
Is it sufficient staffing, what you have? I mean, I believe there's no place in government anymore, regardless of what we're doing, that there's sufficient staffing. But what would be the right number for staffing if it's not? My guess is it's not. But.
It's not, but we're working. You know, we built up originally a 2 CIT office. Remember, we started, and I actually didn't say this, we started this with no money. Okay, the state only gives us money for training, nothing to build up CIT early on. How we did this is a partnership between the Core Service Agency, the Mental Health Agency of Anne Arundel County, and the police chief to say, hey, let's meet together. And the uniqueness of thinking outside the box was we had the 2 officers. What we did is we took one of our mobile teams and divided them, and those 2 clinicians paired with the officer. And by doing that, we actually gained an extra team as well, because now you're taking one team paired of double clinicians and you're putting, that's how we started back in 14 into 15. And that's how we were able to develop this and build. We recently got 4 more officers through a budget increase where the police, the county council, the county exec all saw that it was needed because they were tasking us to do more, by the way. During COVID, we were doing all the health department well checks. We were doing all the school well checks. We were going out on all the follow-ups of things that police couldn't do because of COVID and the restrictions. So we were able to get 4. To be honest, we probably need another 4, and we're actually in conversation of that now. Because what's happening as you're successful is they expect you to do more and more and more, right? And we talk about the judicial system. Problem is we've done such a great job of educating our public defenders, our state's attorney, our judges, that they're now calling us from the bench and from the courtroom and asking us to respond right there to work with them so that they don't have to put someone in jail. So there's all this thinking being done even in just the judicial system that has caused our volume to go up. So that's kind of one of the cautious things I always say when I built Safe Stations program. I said, when we built that, I said, oh, nobody will come, don't worry about it. Fast forward 3 months later and we're at 90 calls for service. So build it and it comes. So we're at a point now where we probably need to be at 12 officers, a lieutenant and a sergeant. We're at 8. But what we do is we explain that we have to take the most severe first, and we kind of work through that way.
2 more questions. In Montgomery County, we have both, for mental health courts, we have both a district and a circuit. Do you have mental health courts?
So we do not have formal mental health court, but I would say we have informal. And why I say that, the judges call us from the bench, like Jen said, frequently. We've come up with procedures to streamline people with substance abuse challenges, mental health challenges throughout the court system. For our clients, the first thing we do is if they have legal issues, we link them to the public defender. We have them fill out the application. I actually send it to the commissioner, get the certification, make sure they're represented first. Most important thing. And then we streamline it through. So we do not have formal, but informal, we absolutely do.
All right, and my last question, I swear. This is so interesting and necessary. Walk me through the call. If someone calls, a family member calls 911, or whoever they call, I'm assuming they call 911, and what happens at that moment?
So actually, there's 2 ways. They can call 911. If it's a family that's already working with the system, they can ask for a CIT team, in which dispatch will get on Channel 5 and ask for a CIT unit to respond. That's just actually 3 ways. Or someone can call 911, patrol can be dispatched, realize there's a mental health call. That's why we train everyone in mental health first aid, just to identify signs and symptoms. That's our big thing, the One Mind Pledge, which we have met. And so they can then get on, our clinicians are on police radio 24/7. They can radio. They can get on the radio and ask to switch down and talk with a mobile team. And then we can determine, is a mobile team appropriate or CIT? Maybe that officer wants to stay on because they built rapport, so our mobile crisis 2 clinicians will come. Or if they say, this might be better if we bring in a fresh set of eyes, we may dispatch a CIT team to relieve that officer from that call, and the CIT officer and clinician pick it up. The third way, which has been our most productive, and I will say our calls for service have gone up on this. In fact, we just presented to the delegation where we showed where our warm line calls are going up, because families are learning not to call 911 in a mental health crisis, but to call our warm line, which is 24/7. They call in, our warm line does a risk assessment and then determines whether they're going to send mobile or CIT, and then we work with them. Now, what we do is educate the family before we dispatch on what a CIT officer is if they've never experienced it, and how the call will look, meaning Lieutenant Thomas or an officer is going to come, they're going to be in a soft uniform, bright blue shirt, his shirt is reverse of my shirt. We're going to come as a team, and this is the goal of the call for service. Reason we like to do that is just to explain the options. And so there are several ways that we can dispatch a team out.
And the nice thing about that too, when the call comes in with officers being stationed there, we can look up things in the police database too to see what kind of history is there. Is there a history of mental health within the police department? Is there a history of violence or weapons and things like that we can then be part of the discussion on who is going to respond to make sure everyone is safe.
And another piece that is unique and why I think it's so important for an officer to be in crisis is, say a family says, I don't want police. I'm like, what happens if I maybe put the officer on and you could talk to them before they come? This is the officer that's going to come to your call, and you can ask all the questions you may have. And if not, we can work on an alternate team coming. So there's a lot of times our officers actually get on the phone with family and have a conversation themselves. We get to a point now where people from the community call in and ask to speak to specific officers through our warm line.
And
Thank you.
sometimes the clinicians get upset because the community wants us more than they want the clinicians.
Thank you very much, Madam
Yes.
Lead.
Yeah, so I was going to point out that if they're calling in 911, right, everyone who's responding can only respond based on the information that comes in. And so the level of detail or follow-up that you all can offer and sort of honing in on that is incredibly important because it helps refine what happens. And then, of course, my understanding of how you all function in the district court in particular in Anne Arundel County is much like, in the civil context, mediators. right? And a lot of the district courts use this mediators in the civil context, and, they call the docket, they go, who's here for this case, who's here for this case, can you all go out? There's a mediator out in the hall, and you can go and talk and see if you can resolve it. That way you don't have to try the case. In your context, it's let's see what we can do, what's an alternative to this being dealt with here in the criminal justice system, what treatment are you going to need? And I know that you all have forms too, because I may have stolen them for another project for the state, that are used to help so that individuals can give consent, so that it helps you all to expedite the connection to the wraparound services that are going to be needed after that initial response moment.
So, yes, we actually, I sign a confidentiality agreement. Every officer in the unit signs a confidentiality agreement with the mental health agency, and the form she's referring to is our release of information, and it allows everyone, the person signs off allowing everyone to communicate so that we can work together to assist that person and the family.
And the key is to do that after crisis so that we can say these are some of the benefits to having it. He's even created a form where they can now say, can you list in CAD that if someone responds, I want a CIT officer, so the call notes can read that. So even if patrol has to go for safety, the CIT officer can be started, because in some cases we've built such a rapport that they are asking that if I'm unclear or I'm unstable, this is what I want when I'm unstable, and we have a form they can fill out. And it actually has stuff like, for autism, no lights, no sirens, or if you have to, right as you get there, shut them off, things that help families. So this goes from mental health across the whole dynamic.
Plus, it'll list emergency contacts of people that if the person's by themselves.
Good, thank you.
Kristen, sorry, Councilmember Mink.
All right. Thank you for being here today. I wanted to understand a little better some of the differences between what we're doing and the Cahoots model, since there are a lot of similarities and clearly there's a lot of things that we like about it. And so just digging in there a little bit to add a little bit of background on Cahoots for folks who might not be as familiar. I'm sure you all are. But it started as a nonprofit back in the late 1960s. The Whitebird Clinic that partners, that works on the Cahoots program in Eugene, Oregon, is a federally qualified health center now that provides primary care services additionally in underserved areas there. They also operate a medical clinic, a dental clinic, drug and alcohol treatment program, as well as the counseling and crisis intervention programs, which was a more recent development. So a couple questions. One is, so as we see, that model began with a partnership with an existing community-based nonprofit, which is different from what we're doing now. Would you be able to talk a little bit about that? About your experience with, or your thoughts on the idea of partnering with a community-based nonprofit, whether that might be a way to help alleviate some of our staffing issues, incorporating that into our model, if there have been thoughts about why we're not doing that now, those sorts of things.
Well, I think my understanding is the way you're running is helpful. I think we're trying to figure out how to build the safer model of the crisis intervention. And I don't know that I can speak enough to the program that you're running outside of that, other than the mobile piece is very similar, and where the concern comes, and I know we had some conversations on 2 of the visits to our site, is when we're responding out, it's the fact that people arrive at different times isn't helpful to the person in crisis. If a clinician's coming here and an officer specially trained is coming and they're coming at different times and we're waiting, or the officer's waiting for the clinician, that's time wasted. It also, if we're coming in different vehicles and we're coming from different locations, we're not staffing on how we're going to approach the call, what we're hearing over the radio, because I might hear from the radio very different than he hears from the radio. Then we come in with very different mindsets, whereas if we're riding together and we're listening, we're processing the call as it happens. Also, afterwards, like he says, jokingly, a couple times we'll leave a call and I'm like, hey, like, you were more the social worker here and I needed you to be more the police officer, and we can have a conversation about where I felt like we went well or we didn't go well. But in regards to outside of that kind of response, I'm not sure that I can speak to Montgomery County side of things. I apologize.
I was going to say, and just to clarify, our folks from Montgomery County PD and from HHS are going to be able to, they're here to address those questions as we move on.
And I think we did both similarities on how we did a grid, so hopefully that'll be helpful.
And one thing I can say about the Cahoots model, I think it's a great model for the person that is receptive and understands that they need help. There's the medical term that I can't pronounce that you're going to,
Anosognosia.
it's the lack of insight. And the layman person, the way I say it is the person's too sick to know they're sick. There's times that in that Cahoots model that I don't believe the clinicians can help unless the person says, yes, I want help. And there are times that for the best for that person and the family is that we take the person for additional inpatient help, in which that point you need the police officer. And that's where I can tell you that we use the least intrusive methods possible. There's many times I've taken people to the hospital unrestrained because that was the best under that circumstances.
And what we're speaking to is psychiatric evaluations. If a clinician gets there and then determines they are doing an evaluation to the hospital, there has to be an officer involved to take them. So now if you're out by yourself as a clinician, you're waiting. That's when things can go wrong really quickly, waiting. And I can tell you that from experience. I've had a mobile team who was out on just a homeless individual who was psychotic, who kind of went down a path as we were waiting for the officer. It took 3 officers at that point to respond, and 1 officer went out on injury because the person became aggressive. There's only so much we can do. If we're responding together and it flows nicely, we're not reintroducing the officer later in the call, I think that tends to risk things more than coming and arriving together and working as a team on that initial call.
Thank you. And that also leads me to my next question, which is, and this is especially important, I think, as we're digging into these staffing issues, because we are understaffed everywhere, and we have to find solutions. And some of those might be creative solutions. And so I'm glad we'll be digging into potential nonprofit partnerships or whatever other ideas we can come up with. But I know that our, MCPD is also understaffed. And one of the things that I've heard from them is that these calls take a very long time, and that's good. We want folks taking their time and not rushing it, but that's a tremendous amount of officer time, and we just need to make sure that we're being very strategic, I think, about how we're spending that time. So one of the differences also that we see in the Eugene Cahoots model versus what we're doing here is, by default, they don't necessarily respond together. They have the option, their crisis response team has the option of requesting police backup either from the start or they can call it in later. And what we have seen there is that for the great majority of calls, they do not tend to call in the police, and then when needed, then they're able to do that. But that is just saving a tremendous amount of officer response time, as well as other potential benefits. So I'm curious if you have any insights about whether or about why our social workers here, from conversations that you have had, tend to prefer to ask to respond with police or to have police there versus the folks in Eugene, or if you've heard any insights on that.
So first, let me explain that. So we're talking about 2 different types of teams here. What you're talking about is my mobile crisis team. So I have tons of teams that go out all day long to clinicians without police. Actually, police call us out, and then they clear, and we stay, and we link them to urgent care appointments, or get, kind of become the mediator between a parent-child dispute, whatever it may be. If we're focusing on the CIT, we're looking at more high-risk calls, where an officer, if they were calling mobile, wouldn't be clearing anyways because there's a weapon in the home, they're under the influence, we have notes that deem that it's an unsafe home, whatever it may be. So I think we're talking about kind of 2 separate programs. If I'm looking at CIT, the one thing I want to be cautious of, and I did an interview, it's about 9 years ago and 3 chiefs ago, I believe, but I was down in Florida being interviewed because we were presenting this model. And one of the things is we can't get caught up in how long we hold on a CIT officer on a call, because over time what you will see is that time spent on a call then is less dispatches later. So I share that there's a person in the community that called 911 90 times in like 6 weeks. 6 months later with CIT visiting, leaving, it took a while. It took a while, and the call slowly went down. We went down to 0 calls between months 6 and 7, but it took time to build up. So part of it is spending time on a call then and educating and spending that time sometimes reduces calls for service. So we have to take the blow early on in the system to show the difference down the road. And I think what we've learned, and it's been a while now, is that it just takes time to get that word out that while I always teach officers, you're always hearing next call in your ear or on the radio, is finish that call, because if you rush that call, you're going to be back tomorrow, if not in the evening. So it's a mindset change that takes time for police to buy in, which Steve can talk to, and for the dispatchers to buy in too, because they're seeing their screen build up. So there is that concern.
It's part of what I described earlier as changing the culture of policing to be helpful. It's sort of, if you want to look at the 21st century policing of being guardians of the community. And with that, in our CIT unit, we're assisting anywhere from 90 to 100 people at a time. And what it is in-depth follow-up with severe mental health or substance use, where is a huge reduction in crime and calls for service. So the year before we started Safe Stations, which is as part of the crisis system, and again, in our co-responding model, we're not taking an officer, and it's not necessarily that I'm partnered with Jen, it's all hands on deck, that throughout the entire crisis system, I might be helping on the warm line at 8 in the morning, at 9 in the morning going on a mobile crisis call, at 11 going on a safe station, and then doing follow-up in the afternoon. It's recognizing up front, if we help people, it's going to be less calls for service and less challenges in the community. The year before we started Safe Stations, which is anyone with addiction can go to any police or fire station or call into the warm line for help. We send an officer in our unit with a clinician. They come up with an individual crisis plan for that person for their recovery. It seems like a lot of work up front. Year before we started in Anne Arundel County, we had 1,824 burglaries. Last year we had 725. Because the people that were pillaging because of addiction are now getting help. And I say that just as an example of the upfront. One of the things I learned from Jen years ago when I was still in patrol is take your time the first time, do it right the first time, and there may not be a second time, or if there is, instead of having the second time be the next day, it may be the next week or next month. But handle it right the first time, and you'll have better long-term outcomes.
I mean, I completely agree with that. And just to clarify, I completely agree that whenever we are responding to one of these calls, it is of the utmost importance that whoever is responding is taking the due time and care to do that, and to hopefully move people into our case management system and be able to provide the continued follow-ups as needed, so we just don't have this repeated cycle. So the line of questioning that I will move on from here shortly and save more for MCOT folks, is because, we have to figure out where and how much we are leaning into, CITs, MCOTs, what the intersections look like, what additional intersections there could be. We have limited capacity. We're going to continue to have limited capacity. There are ways to try to expand the capacity that we want to, look at. But I just want to make sure that I'm giving you the opportunity to provide whatever insights you have about those intersections as we can. And certainly I think that's also, the benefits that you mentioned about taking our time with residents as needed is certainly what we've also been seeing with the MCOT system, including in Eugene, Oregon, where they have seen tremendous reduction in calls from those households additionally. So I think the question, remains for us to continue to dig into, where we want to lean in more to have that outcome. Thanks.
Councilmember Albanese.
Thank you, Councilmember Lutke. Just a couple of questions. The first is, do you guys use peer support specialists in your model?
So we do, but it's very different. So we have the health department who has the peer support where we can refer them. But I actually hire people who are in recovery, but they're care coordinators. So they don't present themselves as necessarily peer support, because to me, peer support is just going out and offer support. Our peers in recovery are throughout our system. They're answering phones, they're doing care coordination, but they go out and they walk them through getting a driver's license, social security card, taking them to appointments. So we categorize them a little different, and they choose whether they want to share that they're in recovery or not, because a lot of these individuals have gone on and gotten furthered their education, and some of them don't want to live in that world anymore. So it's very different. If that, I don't know if I'm making sense. It's really hard to explain, but our peer support people, persons with lived experience, are in our health department, and we can make that referral. In our system, we have people in recovery that are in our mobile crisis teams, our warm line, our care coordination, but we don't specifically hire them just as peers in recovery. Okay. So we distinct it very differently because we do have our health department that we can refer to for that.
And it's very powerful when they are partnered with us, that you have a sworn police officer whose partner is someone with lived experience, and we've had great success with that.
And not just in that, also in our mental health side, we have individuals we work with on our own and different programs like that.
I appreciate that. And then just two last questions. How do you handle multilingual calls?
So I have Spanish-speaking clinicians. We do have the language line. We're actually looking into another system as well because we're not always going to have someone on. But the other unique thing is we have CIT officers, and we look at what shift they're on and ask them to respond to a call as well if need be. So we have a couple of places we can pull from for different situations. But if we don't have anything, we'll use the language line.
And then last question, just logistical. I used to work in the executive branch under the previous administration. Do you have an MOU amongst the various agencies, or has this been like a formal, MOU or any other documents that sort of dictate protocols, and how is that? How does that work?
On the police side, technically, Crisis Response is a quasi-governmental nonprofit, is actually a vendor who was under contract because the police department pays for some of the teams that are being utilized to police calls.
Okay. The reason I ask is just data sharing can sometimes be challenging, sort of across systems.
You mean within like our system
Yeah.
to the police, or we share all the time?
Right.
We do try to keep a chain of command to that. So like our crisis system data will go to Adrian and our head of our core service agency. That way it's shared to the county exec or to schools or to whatever. If schools are asking, hey, how many people called into the warm line, we're going to funnel that through a chain of command up to them, just so that they're not getting it from all different ways. But we release information all the time. Fire gets our dispatch calls to the fire stations and our outcomes. We share CIT information with the police department all the time.
And to add, I actually write 95% more notes in the mental health system than I do police reports. And that's part of that confidentiality agreement that my superiors could call and ask me a question, and there's times I have to tell them, sorry, I cannot tell you because of HIPAA. And they were very respectful of that.
That's helpful. Thank you. I yield back to you.
Councilmember Sales?
Testing?
Yep.
Okay, thank you. Thank you, Councilmember Lutke, for calling this panel, the series of panels. I wasn't sure if we were going to do a full discussion of all three panels or do them one at a time, but I will just ask questions as we go on. And so, how old did you say this? Is it the counselor in training or the mobile crisis response?
The mobile crisis, which is two clinicians that respond together on police radio, has been around since 1999.
Okay. And
That is under a federal block grant.
okay. And did you bring any data points of the response that you've been able to track since the program's inception?
Well, we as mental health agency took over midway through, so it was contracted through a provider early on, and that changed in 2013 and 14 where we rebid out. And we originally just took the warm line and had mobile still with a provider. And then 2 years later, we took mobile crisis and the care coordination and the warm line in. That is when CIT became introduced into the crisis system. So early on, we were just mobile crisis and a warm line. We weren't, police would dispatch us on police radio to calls. It wasn't until 2014 that we began partnering where we were looking at bringing the officers in-house. So we had mobile around for a while before that.
Okay. And do you have any data to describe the response and who's?
I do. I didn't bring any data with me, but I mean, I'm sure we could share.
Yeah.
Can follow up with that.
Oh, okay. Just to, better understand if this program is, are you seeing the positive indicators from the program that you originally intended, and what have been some of the trends that you've seen in the response? I know you mentioned one statistic about crime going down in one particular area. Was that robberies or
Yes, and it was burglaries.
burglaries?
And we do have a lot of additional data that, with that when you offer people assistance when they're ready for it, and they want it, how successful that is. And then with us as police becoming their social supports is very powerful.
And one of the things I'd like to say about data, this is just a pitch I always share, is while data is important, remember the data you don't see is the success story. So the calls that don't happen, and I always say to the chief when I'm talking, I wish I could share every story of some positive outcome because that data point isn't usually seen. But what we can show is the uniqueness of how many CIT visits occur after a call for service for follow-up, which is really unique. It shows the amount of willingness for a person in crisis to want a follow-up visit where the officer is present versus mobile crisis who is constantly like going from call to call to call because they're on police radio. And I'm happy to share some of that with you.
Yes, yeah, that would be helpful. And what's the budget for the county CIT program versus the crisis response program?
I believe Adrian Michler from my agency was supposed to be providing all of that to someone here because I'm the boots on the ground crisis. I don't do the budget piece. Sorry.
I believe we have a request out for that information, so
Yeah.
we'll have
I knew it
that.
was there.
It's just not in
Adrian
the
said.
packet. Yep.
And Councilmember Albornoz, Chair Albornoz mentioned, the language proficiency of the counselors. How do you train your teams in cultural competency?
In our system, we have classes that they're taking, as well as we actually we've started in what's called the aid committee, which is our counselors have gotten together, and when we hit tough, difficult calls, we have brown bag lunches where people can get together and staff those calls because we do have a lot of situations in calls where things maybe are uncomfortable or we're not sure how to address them. We come together and debrief. And a partner may say, I didn't like the way you handled that call with me. They were clearly avoiding me for a specific reason. And then we discuss how we can do better on the next call. And so we do a lot. We bring in a lot of the critical incident stress management model and debrief our staff after difficult calls. And then look at ways that we can better ourselves for the next call for service where we may be dealing with some kind of diversity situation.
So, in Montgomery County, the previous council named racism as a public health crisis, which resulted in an Office of Racial Equity and Social Justice. And so every initiative, every piece of legislation now has a racial equity and social justice impact statement. And so a program such as this would come with the same sort of robust oversight and opportunity for evaluation. So if you have any information on the demographics of the counselors that are included in the CIT program and in the mobile crisis response program, that would be helpful to ascertain the impact. And then, my sister lives in Anne Arundel County, so I know that, this is a very diverse community, and so that would be helpful to understand if the people who are calling for mental health responses are actually, those are being resolved in a very compassionate manner. So looking forward to getting that information.
What I can respond to that, maybe not at the time of the call because we don't know what we're walking into, but our follow-up calls for sure. We can staff and make sure that we have the right fit for our follow-up stabilized visits. I think it's hard on the initial calls, like we will find in some of our Hispanic community, our clinician may not be available because they're already on a call, but we can make sure when we do that follow-up visit, or if we have to switch up in the middle of a call when it's appropriate, you can do that. But I just want to say on initial calls, sometimes it's super difficult because calls are always coming in. You don't know where your teams are and where you are. But when we get to follow-up is where I think we can look at doing a better job across the board of making sure the right person is doing the follow-up that is helpful for that individual.
Yeah, I'm sure that, with, a few years of training and data, that it would be helpful to see where there were holes, where there was a need for a diverse response, and what hiring needs would inform a better response. And so that's why it's, I'm glad that we're going to have 3 different panels, but, my background is in program evaluation and public health. And so I'm always looking at what are the numbers and, what's missing from the program. But thank you so much for
Also,
sharing.
I'd like to add, at crisis and the police side, both organizations are very representative of the communities that we serve. And we, across all segments of the community, are working with us in the units. Alan Marcus was named the 2018 CIT International Officer of the Year, as in the best officer. He's an African-American officer. We've worked together for years, and that's where his heart is.
Okay. Thank you so much.
You're welcome.
Thank you both for coming. I really, okay, we have a time constraint that we have to, okay, if you
Okay,
can go
real quick
quickly.
question. Just one more quick request for data question. I don't know if we have it or could follow up later and get it, but just looking for, following up on Councilmember Sales' questions, breakdown racial demographics for mental health calls, as well as use of force breakdowns.
That'll be up to the police department. I can break down demographics very easily for the crisis response data because we have that. That's pretty, but remember, it is Anne Arundel County, not Montgomery. So
Right.
I just want to be clear. You're asking for a lot of our data. I just want to make sure, understand that's representative of Anne Arundel County, not then making sure that we're comparing correctly. I just want to, I'm happy to share. I just.
Really appreciate it, and really appreciate you taking the time to come and
Absolutely.
share your insights so we can help to, so we can learn from your community as well.
And if you're looking at use of force, I guess, for the department as a whole?
And specifically also in regards to the mental health calls and across the
Okay.
different
Yeah,
response
that's something that would have
mechanisms.
to go through the police department, I guess,
Okay.
through a public information request.
Oh,
I'm not involved in that
We'll
aspect
have,
of it.
yeah, we can have our central staff reach out about that. Just everyone bear in mind, data is different and will be classified differently because of changes in the law. And their data on use of force may be different than data pre-July 1st, 2022 in Montgomery County because there was no standardized definition of use of force until July 1st, 2022. So it's not necessarily apples to apples, not just based on population, but also because they were defined differently by departmental policies. So there are differences in data across the board. So things to bear in mind.
Thank you.
Thank you for coming, and we're going to do a quick switch out because I know we have a time constraint, and we're actually going to go out of order from what we were planning to do. So we are going to bring up the MCPD CIT group presently, who has a hard stop at 3:30. And so with us today, we have Captain Jordan Satinsky, who's the Director of Community Engagement Division. Lieutenant Kevin Parker, Deputy Director of the Community Engagement Division and former member of the state's active assailant interdisciplinary work group that I served with, and Sergeant Chad Matthews, Crisis Intervention Team. So thank you and welcome.
Thank you very much for having us. I actually had prepared remarks, but I'm going to toss them aside after listening to Lieutenant Thompson and the director just speak about their program in Anne Arundel County. We did get to go down there and speak to them. We also got to go with the councilwoman up to Baltimore County to their project as well to see how they have interacted between their clinicians and their police department. Chief Jones has recognized that we do need a more robust response to this type of call for service. This group, the CIT group, has been around since around 2001 when an officer on her own, officer named Joan Logan, just kind of developed it. She started it up and she used to have these forms she'd have us fill out, and she'd painstakingly go through every single form where an officer went on to a mental health call, and she'd go back through and highlight where we made mistakes and send them back in inter-office mail. And I remember as a young officer when this first happened wondering what I had done wrong in this form compared to all the other things I had to fill out in triplicate. Going with my data hound over here, I completely sympathize and understand that. It's a compliment, man, absolute compliment. I think as we moved forward, we still had this single officer for quite a while. We started to add people, but it was really more or less a kind of off-the-cuff situation. It wasn't written into our rules. It was just kind of, these are people that wanted to do it. And eventually, we ended up with 2 officers. PO3 Logan retired, and we had 2 officers in there who really built it out. And eventually, Sergeant Matthews, seated down on my right, came along and really started to build this program up and make it more robust. I showed up in community engagement back in September, and he came to me with some ideas about how to expand this program and deliver better service to the county. Now, my background, for you all who don't know, is my whole background is basically violent crimes as an investigator. I was domestic violence. I created the sex assault unit here in the county. I brought our police department over to the FJC with then almost Sheriff Max Wee behind me. And we really built together between us and Mr. Maloney all of these relationships. So when Sergeant Matthews brought this idea of building relationships and more robust relationships between us, potentially private entities, and HHS, I bought in right away. The problem was, like Councilmember Lookey said earlier, staffing, right? I don't have a lot of cops. We're losing people left and right. As a matter of fact, while I was standing back there, I got a notification that another officer who's been here 5 years just resigned today. So it's happening on a regular basis. So what we did, we looked internally, and I just moved some things around with Chief Jones' permission. We're adding now, we're going to have a total, when it all comes online, 4 spots under Sergeant Matthews, and we're creating another unit called the Behavioral Assessment Administrative Unit, which is going to be doing the bulk of the statistical work as well as the background work on the folks that Sergeant Matthews' group actually focuses on currently. What I learned watching Sergeant Matthews' group is that they spend an inordinate amount of time in the office. And I don't like cops in the office. They end up like me. I need them out there. So by having someone do the background work and shipping it to them electronically, I can get these guys out on the road. Chief Jones agreed, and we're going to start a pilot project as soon as I get my folks online to put at least 2 units out in our highest service areas for mental health calls in the county, probably be the southern part of the county to begin with. And we're going to probably go through that for 90 to 180 days until when we see kind of where our data fleshes out. We've created data models and ways to capture that information so we can actually come back and say, hey, this is working or it's not. We've also engaged in several discussions with HHS about pairing up the clinician with the police officer. What the director said, which Director Corbin said earlier, I completely agree with. We have our MCOT teams, which are awesome, our mobile crisis teams, which are great, supplied by HHS. And these are people with lots of experience. They've been with us, and we've had this group working together for 20 plus years. Awesome relationship. But then I have my cops who are over here. And like she said, when we're responding from 2 different areas for a person in crisis, it causes problems. We're not able to set up and determine what our dialogue is going to be. I never went into a single interview or an interrogation as a homicide detective or a sex assault detective without talking to my partner first and making a game plan. That's what we did. And then we're showing up on scene and trying to make a quick game plan. While sometimes in lower situations it may work, in the high stress situation it may not. By putting them together, they can game it out and figure it out on the way. And that provides better service. As a matter of fact, information that I've read throughout since I started this project, DOJ's Bureau of Justice Assistant actually recommends these kinds of teams as combating mental health issues for those in crisis when the police department is involved, because you have the expertise of that therapist with you. Look, there's not a person in this room who's going to tell me, well, the exception of Officer Cox, who's behind me, that cops are therapists. That's it. She has an MSW. She doesn't like me talking about it. But we're not. We're supposed to come in and help fix a problem, right? My CIT officers are trained differently to approach that problem differently and look at it from imaginative ways, still within the scope of the law and still within the scope of safety. But by having that therapist there to not only work with the client, the victim, the person, it also imparts education on my cops too. And it's infectious and it gets out there. Like Lieutenant Thomas said, having CIT officers trained that are voluntold or forced to go into training, look, I've trained all over the world. I can tell who's been forced to be in there because they're doing this and they're on their phone the whole time. Those who are engaging, they're looking at you, they're talking. Those are my CIT folks. Those are the folks that want to be out there and engaging with the community. So moving forward, 2023 for the Community Engagement Division is going to be a big year as we've already started making these changes. My hope is within the next 6 months, and this is government 6 months, as everyone knows, so it might get stretched out a little bit, is to have this in place and to have these things out there so we can respond to folks and work with HHS and any other partners to make this work. And we'll be happy once we start getting this information to put out what we can that's in line with HIPAA and everything else, that we can to show where this is working and to show how to make this more robust. My end result, my dream, would be in a few years to have these teams running 24/7, 365 between the top end of the county and the southern end of the county, responding to calls for service that we believe, based on how the call comes in through the structured call type analysis at our emergency communication center, would trigger these folks. But that doesn't mean that if an officer goes on the scene of a parking complaint, it may not trigger the CIT folks either. That officer could get there and say, no, they need to be there. Or MCOT could get there and say, I need the CIT team here. So we're leaving it very open. And that's where we are at this moment. Lieutenant Barker, Sergeant Matthews, do you have anything you want to discuss? Sergeant Matthews has the most knowledge of all of this, and he is my subject matter expert.
Thank you for having us here today. And I could go on and on about why I think we need this program, and I've been pushing so hard since I got in the position in March. But, you know, Captain Satinsky spoke very eloquently on all the matters that I really wanted to hit, so not a lot for me to talk about. However, I can tell you as a road sergeant for a long time, I would be on these calls, and I saw the need for it. There was a significant need, especially down county where I worked in downtown Silver Spring. There's a tremendous need down there, and the officers can't handle it. They cannot handle it, and they're not in a position to win those challenges. So this model really will help us help those people better, because again, we're focused on the individual, and for us to help that person we know by first name, we know these people, everything about them, their family history. However, we can't help them, and they call us repeatedly, and they want us to help them. So we have a need for it. There's a lot of passion from me, and a lot of the officers on the department have a tremendous amount of passion to help these folks. That's why we got into law enforcement initially, to help people. That's what everybody says in the interview. We want to help people. This is the opportunity for us to help people. Thank you.
I just want to add, so I think we all know there's plenty of work for all the teams that we've talked about up here. As the captain mentioned, MCOT does a wonderful job. They actually have a very advanced triage system that the police had input in. So that's part of our future moving forward. Part of what we see with the CIT teams is if we can have the greatest clinicians in the world out there, but if we get there 30 seconds too late, we're too late. And that's part of the importance of having this team out on the street, being available to get there when seconds matter, really.
Thank you. I had the opportunity to do a ride-along a few weekends ago, and I actually ended up on a call that was a call for a suicide. The gentleman, in fact, I believe, did live, but it was a situation that went south very quickly. There wasn't a call for any kind of mental health support that was made. There were a host of individuals present at the time, so it was impactful not just for the individual who used a firearm on themselves, but for everyone who was present at that time, and an intense amount of resources to manage the scene at a very traumatic moment. When, again, if we could have more resources deployed on a prevention-intervention basis, and then we can reduce these types of incidents overall for the betterment of all. Chairman Katz, you had questions.
Thank you very much, Madam Lead. I don't know what you call. I guess it's the lead on this. Yeah, I can call you. You can call me Sydney. It works for me too. Thank you all for doing what you're doing and for being here. And I mean that we haven't seen each other in a while. We've seen each other in various committees along the way. How fast is the response time?
As far as to any,
You get a
any
call.
kind of call? Or?
Yeah, you get a call. How fast can you get to the
really-
person?
It really depends on where the officer is, where the location is, or, the way our beats are currently set up. I think the average, and don't quote me on this, I can get it for you, but I believe the average is 5
You have
minutes.
Susan Farag sitting there. She'll get it for us. Go ahead. Go ahead, George.
It was, in the last year's report, it was 8 minutes, 46
8 minutes?
seconds.
Okay. And that's, a lot of that it does, because of our attrition rates and the way that people are leaving the department, we know we have less staff on patrol.
Believe me.
And also, we are spending, much like Director Corbin talked about, we are spending more time on these calls. And she's right, I do agree with her. The more time we spend on the front end, the less time we have to spend on the back end. And I will tell you, as a young cop, I didn't believe that. You came into the call, you dealt with it, you left. And how many times did I go to the same house for the same thing? You could predict it at some point. Oh, it's 4:52 on Friday. We'll be going to House A in a few minutes. And sure enough, we were. But we never took the time, because our job then was go in, control, leave. Now it's go in, calm it down, figure it out.
And how much inner workings do you have with the mental health courts? Do you have
So
any?
we do have, Sergeant Matthews, right before my arrival, actually created what he calls a crisis stat, which is a partnership between many entities in the county, public, private as well, where they discuss not specific cases per se, just because there are no MOUs in place currently, but process. We do have some context with the State's Attorney's Office in there as far as how the mental health court works and the voluntariness and how to get people in. But again, we run into the same issue. It's voluntary. And for those who are offered the mental health court option, it doesn't always happen. I mean, I personally will tell you, I have a very close relationship to the whole Capitol Gazette thing for a whole other reason. But the person involved in that was, from what I recall, offered the mental health court and declined down there as well. So, yeah.
Well, I can tell you, I go to their graduations, and it's pretty gratifying.
Yeah,
I mean,
that's what I hear.
And sometimes it takes a couple times to get there.
Like anything
for a
else.
person, but they do save lives.
Yes.
Absolutely save lives. Thank you all. Yield back.
Anyone else have any questions for this panel? Okay. Councilmember Mink?
Hi, thanks for being here. A couple questions. When police encounter a person displaying mental or behavioral health difficulties, are they instructed to call HHS crisis response, or what does that look like?
So it really depends on the situation. I can't give you a pinpoint answer. It really is much like Director Corbin and Lieutenant Thomas said, when you get on the scene of one of these things, it's one thing. You can de-escalate it depending on the situation rather quickly sometimes, and that would then trigger that call to HHS for their MCOT team. They may call out right away if the officer's senior enough and realize it from their training and experience. It just depends, and it depends on what kind of level of threat they are as well to other people. If they're an immediate threat, and let's say they're in a crowded area, we're not going to leave them there to continue that threat. We're going to try to get them out of there and get them to a safe place. Because sometimes having the audience brings things up. So getting them out of there to a neutral location brings things down. And then they can be assessed and move from there.
Okay, so that'll be another data point that would be good to dig into, is how many mental and behavioral health calls, begin with police response and then, result in additionally the calls for MCOT or not, as well as, the outcomes of those calls.
We are keeping certain data on that. We're actually been restarting that whole process in the last month or so. I don't have enough to share at this point, just because it hasn't been a long enough time. So I need some more time to go through that.
Okay. Question in particular, we've seen some statistics that show that police are frequently dispatched to Progress Place.
Yes.
In downtown Silver Spring. Is there a plan or an intention to transfer some of those service calls to HHS or the crisis center, or is there, as we're talking about the repeated calls and looking for ways to shift the burden?
Yeah, Sergeant Matthews actually was working on something.
Right.
Yeah, so that's where I worked for a long period of time as a patrol officer, and then after promotion and coming back again to that same area. 8106 George Avenue is a call volume. It just gets a ton of calls. And it's a lot. People homeless, people with substance abuse, people with behavioral issues. So it's a great place for the community. However, sometimes people call and they don't really know what they're needing. So then they dispatch the police. So absolutely, this pilot project that we're starting, that's where we want to start. That's my ground zero. That's where we want to focus a lot of energy right off the bat, because that's where the biggest need is, absolutely, in the county. So as far as diversion, just working with the staff that are there, the clinicians, Interfaith Works is there, Shepherd's Table, working with them to utilize us as a resource, because right now you get a patrol response when you call.
Right. Right, and one of the things actually that Interfaith Works mentioned recently, and since you have expertise on this area, then I'll mention it here too, is that they wish that there was more security folks available to be on site with them during the day, and so that is I'll just flag for another day a staffing issue for us to also dig into. That would hopefully cut down on the number of calls there as well.
So I'm getting ready to turn it over to Councilmember Sales, but I know the question you had asked was about time when patrol called, mobile crisis called MCOT after. There was data in the packet too that showed the number of calls to MCOT that subsequently needed co-police response or required a co-police response because of the type of calls they were, and we were still at about 50% of the known. There was a category that was unknown that was maybe around 25%-ish, and then another 25% where MCOT could handle the calls alone. So that's sort of the landscape of the data from the initial call coming in to the triage protocol that is currently in place for our emergency call center. So, Councilmember Sales.
Thank you, Madam Lead. So thank you to our officers and to our, I guess, CIT team mates.
Yes.
CIT lead. Thank you so much for the presentation and the updates. Councilmember Mink asked a similar question I'm going to ask about how are we educating the public about how to contact non-emergency lines when needing a CIT professional versus a police officer. And what is that number? Is it 311 or?
988. So it's like the lieutenant and Corbin had mentioned earlier. It's interactions. It's through word of mouth, essentially. That's the best way to do it. When you interact with folks, hey, you don't need to dial 911. Just call this number. And you may get me as well. Like if you want to see me, a lot of people like me, so they may want to have me come out. So that's another way for them to get us instead of tying up that 911 system. So it's just word of mouth, essentially. HHS, I don't think we're going to go back and forth on how they're going to roll out that 988, how they're going to kind of announce it, but
So there is a plan for an outreach and marketing plan in all the top languages that are spoken in the community. Oh, good. Okay. So I'll save that question for your panel. Okay. All right. I know that capacity is a huge challenge. We were talking at the Renters Alliance meeting last night. We were joined by several police officers from the 3rd District. And so I know that there's quite a few dollars left over in our budget, and that, the council is very supportive of providing the resources necessary for additional capacity. I know that overtime as well has been supported throughout the force. And so what is your overall vision regarding building that capacity and attracting new staff?
So we have a new management and budget director who came on board earlier, mid-range or so last year. And he and I and Sergeant Matthews and Parker have been talking. We have engaged the U.S. DOJ COPS office to look for grants, as well as looking for and I can't remember what the acronym stands for, but it's CRITEC, but it also falls under DOJ grants where you can put in for equipment in order to, use over the next 3 years. That money's for equipment until it becomes part of your own, part of your budget process in a new program. So this is kind of where we're going. My plan is I would like to have these units unmarked. I've actually gotten an unmarked car put into service in this group. I'd like them to be in soft uniforms. I don't want them in this. I'd like them dressed not in the blue of Lieutenant Thomas, but something a little less flashy.
Sweater vest.
A nice sweater vest would be nice. And I don't want cage cars. I want muted light bars. I want, they have to have sirens because they're emergency vehicles. But outside of that, as best we can to minimize our interaction or showiness of where, of us being there. My hope The funds would come from that, as well as combinations from, internal sources within the county as best we can. I honestly don't know how much staff I'm going to need in the future. This is still kind of a beginning. When we started the sex assault unit, I had 3 people. There are 11 there now. So I'm starting with 4 here. I'd like to have as a robust team as Baltimore County has, which Councilmember Lukey remind me, I think it's 26 teams they have out there running around 24/7. But they've had a decade to build that, which they continually reminded me when I was in there as a kid in a candy store being like, oh my God, look at all this. So it's going to take a while, and I think that's something everyone has to really understand. I mean, I joke about government time, but I'm not really joking there. It's slow, and we do that purposely to make sure we're going the right way and where we can make tweaks. This is a needed thing. There isn't, I would dare say, a person in this room that's either hasn't had some sort of a touch with the mental health system or knows someone who has. I mean, I do throughout my family quite a bit, and it's not an easy system to navigate. It is filled with blocks that are sometimes purposeful, and you have to know the right keywords to plug in order to get around them, which is unfortunate, and that's not how it should be. I would envision this as being as open as I can. I want my police, I don't want them there to be the enforcement angle. I want them there to be the assistant angle. That's what they should be doing. The therapist should be there taking the lead. The cop should be there helping out. Much like Director Corbin and Lieutenant Thomas talked about earlier about their role switching back and forth, I could totally see that with the right teams. Absolutely. But we have to start building it. What we have now has been working for quite a long time. We just want to expand it. The MCOT teams are fabulous, and they totally hold a role. And MCPD and HHS have had a 20-year relationship. I'm not looking, no one in the police department is looking to end. All we're looking to do is expand it and make it more robust so we can help our folks. Because otherwise, if we don't, you're going to have me here for another reason, I'm sure, one day explaining why. So I'd prefer not to have that happen. Not only that, we owe it to our people. We owe it to the people we serve. And that's one of the reasons why I took the job, as well as Sergeant Matthews and Lieutenant Parker.
I appreciate that. This joint briefing is just, the first step to holistically and robustly address, this real threat to our community, mental health challenges to our community. And so, every year there's a budget season, and every year we're going to watch closely the recommendations that are included to ensure that we're meeting the needs of our most vulnerable populations. And so, one last question, because we're having this meeting. Maybe this will help facilitate an MOU between this program and HHS regarding the capacity and training that would be helpful to ensure that the funding is necessary based on, prior calls and, 8 minutes, I guess, is, a very reasonable response time. And so, if you can, I guess better specify where the needs are so that Health and Human Services understands what that would look like, and we understand from the budgetary perspective.
And we want to do that. I want to do that by putting these teams out in that pilot program to see where it is, to get that idea, and to see how much we bring down our response times potentially to these types of calls for service specifically. Because think about it, if anyone ever hears call 911, even 30 seconds, if I happen to live up the street and come down, that's an eternity to the person having the crisis or the family member witnessing it. Sorry, I didn't mean to cut you off, man.
No, not at all. And then one other question I had was about, it looked like there were 152 MCOT calls where it's not known if police were involved or not. Is there a system in place to track these?
We have that now.
Okay.
I can't give you too much more at the moment based on what you have there. HHS might have something more, but on the police side, our data systems are separate. And we put into place something through the assistance of Sergeant Matthews to make this work a little bit better so we can answer questions like that. But again, it goes back to the same thing I said before. It's going to take a while for us to get that information built up.
Okay, so,
Yes.
so no information regarding those?
Not at the moment. I mean, I'd have to go back and take a look, and we can.
Okay.
I just don't have it. I can't tell you for that whole time. I can tell you probably for some of it, but not the whole thing.
Okay, and then Councilmember Albornoz may ask about the language access, but I wanted to ask another question just about the cultural competency of the MCOT teams and, what that looks like regarding.
Much like Lieutenant Thomas said, we pull from the community we serve, and we put people in these positions for that reason. I have no tolerance, nor does Chief Jones, for any of that, any kind of basing anything upon race, religion, or anything else for that matter. As a matter of fact, my division also does all the hate crimes for the county as well. So they're all well aware and get to see the weekly reports about what comes in. They get to see it for a reason, because exposure breeds empathy, and I need them to have that. I need them to understand it. And the cops that show up in the CED division, they're my CEOs, the community engagement officers, the CIT folks. These are folks that are not your usual patrol officers. These folks want to do something different and look at things differently. So they will go out and get themselves educated, and they have. I haven't had any instances with that.
But there's no.
We have the formal training programs in the county training academy. Yes, I don't have one in the division, but in the training program and as well at the state level, we have requirements that we have to meet every year. Yes.
Thank you.
You're welcome.
Yield.
And just a couple of data points based on what you were asking them. And Lieutenant Parker, you can probably back me up on this. In mass casualty events, they're usually over under 5 minutes, correct? Yeah. Right. It's very quick, deadly, and done, usually before law enforcement can reach the scene. With respect to some of the training that I know you all have done even prior to the state mandating it for all law enforcement officers on hate bias and hate crimes and understanding all of the different protected classes and the nuances of all of that. And because I had helped with your PowerPoint for that way back in the day, before advocating for that change at the state level so that became state law mandatory for all officers, both in the academy and every 3 years within in-service training. So I turn it over to Councilmember Albornoz.
Thank you. And I think one or two or maybe all three of you had a hard stop around 3:30. So if any of you have to leave, totally understand. I can follow up with some of my questions. But I want to pick up where Captain left off, which is the fact that this is a broader issue. We're talking about the point in time when officers are engaging, a call is made, a referral is made. We're doing our best to address the situation holistically. But you mentioned, Captain, you're absolutely right, the repeat situations, the families that are going through this. And I've spoken about this publicly before, but it's appropriate for me to mention this now. This happened in my own family with a relative of mine whose parents did everything humanly possible to get him the care that he needed. And unfortunately, for a variety of different reasons, because of the complexity of the system, because there wasn't a bed available for him when he needed it, he began to self-medicate and went down this very dark path that led to a very unfortunate incident that my family will probably never fully recover from. So I think as a follow-up to this, it'd be valuable for us to, once the legislative session is over in Annapolis this year, that we revisit once again what more we can do from a mental health infrastructural standpoint at the state level, now that we have a new administration who is open to looking at things from a different perspective and assisting all of our providers, as well as our first responders and our healthcare specialists to be able to address what is definitely a complex issue. So I appreciate that. So the other thing that I wanted to mention was in terms of recruitment and retention, which is obviously, we're all trying to do the right thing here. And we have formed this group, and in a follow-up and subsequent conversation, I'd love suggestions from you all on what we can do to help recruit and retain officers that are willing to do this work in partnership and in collaboration with our providers, specifically in HHS, because it takes a unique skill set and one that requires much more training than is currently offered. And we do want to be that best practice for sure. So would love some thoughts and suggestions on how we can improve upon that in the future. And I'll yield back to you so that we can kind of continue the conversation, but I appreciate all of your efforts and I look forward to the continuing evolution of this really, really important program.
And to your point about state resources and availability of beds, which is another discussion that we're definitely going to have to get on the calendar. Quick fact, we have less than 20, I believe, 20 total beds in the state at 2 different facilities for adolescents who have coexisting mental and behavioral health needs and individuals with disabilities or autism spectrum disorder. Less than 20 for the entire state. Let that sink in. So, Councilmember Mink.
Thank you, and absolutely, that's a big deal. I'll be quick too, and I'll follow up with other questions later. Appreciate the time. I think that we all recognize that there are severe staffing issues everywhere, and we have to be very thoughtful about how we, spend our budget, and on where. Security services, also under MCPD, was not previously, but is currently. Just thinking about how, you're talking about the possibility of adding 4 officers on CIT, and other things. So thinking about how that decision is made, about where to put that funding. And also, I think that one of the big decision points ahead of all of us is looking at how much we are leaning into CIT response versus MCOT response and or overlap of the two together, right? And it is the more efficient we can be, especially given the staffing constraints, I think we can all agree that that is better, and be able to, if we are able to have fewer people responding safely with a positive outcome, then we are able to put those resources somewhere else. We clearly, MCPD, I know, has a lot of needs in a lot of places that you've mentioned, and we all have limited resources, right? So certainly we'll follow up with some questions to help to try to break down the results of those calls, the MCOT calls, the CIT calls, and figure out how we can reduce resources and where those resources are best spent. But wanted to see if you had anything to say about, any more to say about that, and also about, some of the more preventative services such as security services versus CIT response.
As far as moving forward and what we have currently allotted for our police sworn complement and how to readjust those, that's been an ongoing discussion since I became an executive about how to reorganize ourselves to make ourselves more efficient. It's not an easy task, right? And it's not something that you do overnight. I mean, we went to a sector model of policing 15 years ago, 10 years ago, something like that. And, we did that based on trying to allocate our resources to insert ourselves into the community more deeply and make more community contacts. That was done after a long study to see what would work and where, and they put those sectors into those places to make that community contact. As far as our resources internally, moving towards the CIT thing, I actually, with Chief Jones and Assistant Chief Yamada's assistance, we moved positions that were in the Oracle system, the OHR system, in order to facilitate not having to hire or deplete anything from the road. So I didn't take anything from Patrol Services Bureau. I used what I had within my division and moved them around based on some vacancies and things in the division. So I didn't take from anywhere. I just moved some things based on what I knew from data that wasn't working as well as it should, and we needed these resources in other places. As far as security services, that doesn't fall under my heading, so I can't really speak to it. I do apologize. I have no control in that area, nor do I have much insight into it, I want to be honest. They do a very good job for us, but I don't have any further information on that division in and of itself. Did that answer all your questions? I'm sorry.
Yeah, so I'll just note that from my understanding, that department has shrunk dramatically, and is.
That part is true, yes.
Yeah.
I had heard that as well, but I don't know the numbers or anything, sorry.
No worries. We can follow up with questions. And then also acknowledging that even if we're not shifting people, that certainly when we have officers who are responding on these mental health calls, that is fewer people in other places, which is something that we've heard,
Yes.
from the community for better or for worse as well. And so a consideration.
If there are no further questions, we'll let this panel go unless you have any concluding remarks you'd like to make.
No, thank you guys for putting this together. We really all appreciate it. I know the folks from HHS are going to come up, and
Yes.
we're really excited to work with them and continue this. So thank you.
Thank you. Thank you very much.
Thanks.
All right, now we're going to bring up our team from HHS. And as they're coming up, I'll introduce or let everyone know who's here with us today. So we have Dr. Raymond Kroll, who's the director of HHS, Dr. Roland Santiago, the chief of our behavioral health services, Amanda Harris, no, is not here. Yes, Dornay Hill is here, senior administrator for crisis intake and trauma services, and Beth Tabachnik, manager of the crisis center. And thank you, two of you I've met for the first time today, two of you I have interacted with in the past, and I'm greatly appreciative, and welcome. And we look forward to hearing your presentation and being able to ask you questions. Thank you.
So good afternoon, everyone. I'm Dr. Raymond Kroll. I'm the director of the Department of Health and Human Services, literally for about another day and a half. Before, as Councilmember Albernos pointed out, I'm going off to do some other things with my life. I want to thank you all, first of all, for convening this meeting. It's in this hearing and this session, because there's a chance for me to talk about something that has been near and dear to my heart for a lot of years. I'm a psychologist by training and have built at least 2 crisis response systems across the region. So it's something that I care about and have some experience in over the years. On a personal note, I just want to say, since this is my last meeting, I just want to take a moment and say thank you to council members that I'm rejoining in this session, but also to new council members who are joining, and to say that I am. It's been a delight, and I've appreciated the respect and the support that council has given me and this department over the years, especially in the last several years, and it's been an honor to work with you all. Gabe, you know well that where I am in this, and I would argue that the pandemic changed my focus, but not my intention. The work has always been promoting the health and well-being of the county and the county residents, and I expect that will be will continue to be part of my mission. I expect great things from you all in the future, and I will be watching as a private citizen and as a voting member of this county, and I'll come back and fuss with some insight. To the topic at hand, I think that this has been an amazing conversation. It's been hard for me to sit in my seat and not want to jump up to the mic and just weigh in on this conversation, because it's been really rich to hear from our colleagues in Anne Arundel, and to hear from the perspective from our colleagues in the county police department. What I think is missed in this process is just the degree to which there's an integration and a synergy that has existed for a lot of years that we are now building on and working to grow and enhance. There are plenty of challenges, plenty of problems that we have to address, but there's a level of cooperation and collaboration that I'm hoping will come through starting today, because I'm leaving, I can do this. I'm going to suggest, Councilmember Lutke, that you do ride along with one of our crisis teams at some point to get this sense of how the mobile crisis outreach teams work and how they work in conjunction with MCPD.
I have a host of various ride-along things coming up. So yes, thank you.
This one will mirror the police ride along.
Yes, no, I know. Oh, I have them with all manner of folks. So thank you.
I'm sure they'll be happy to have you. They're going to fuss at me a little later, but that's okay. So, the Health and Human Services, Fire and Rescue, the Police Department, and our community partners have spent a lot of time over the last 2 years working on how we strengthen crisis response in Montgomery County. And I just want to point out a few things that have changed in the last 2 years during my time as director, but also during the pandemic. This started with some interest in increasing the amount of civilian response and the civilian response capacity in the county. We've had mobile crisis and CIT teams for a long time, but the council gave us $500,000 2 years ago to allow us to expand mobile crisis and increase our capacity to respond. Prior to that, there had, because of shrinkages in the HHS budget and downsizes in county budget, we had reduced our mobile crisis outreach team to 1 team for the entire county, which is, for 1 million people, that's just inadequate. And what that has meant is that law enforcement has had to take on an increasing role in responding to human services, mental health, substance abuse, and homeless services needs. The reality is that given the number, and MCPD did not talk about this, but given the several thousand calls a year, this is a big historic problem that it is going to take time to work our way through, and we're working to change that culture, I think. So the civilian response, the civilian crisis response was a mandate. And I think the other piece of this, of course, has to do with how we deal with the cultural issues and the sociological issues we are now faced with in this county and in this country, and how we, in the interface between the community and law enforcement. We've had CIT in this county for a lot of years now, and I just want to, as a point of pride, point out that CIT team received the CITI International Award in 2011, I think it was. Was that? I'm sorry.
The first Maryland State CIT
The first Maryland State CITI Award. It does. So there's and has trained any number of CIT teams around the country on this model. So they're a great team, but we realized that we needed more, and that $500,000 allowed us to expand and add 6 new clinicians to our mobile crisis teams and expand our teams a little bit. The first significant impact that made was that we almost doubled the number of mobile crisis outreach responses we were capable of doing, from just under 500 in 2020 to just under 1,000 in 2021, 98% increase. And then the second piece of this thing that we did was that we recognized that responding all over the county from Rockville was not a great idea, so we created 2 satellite areas. So we went down county and put an office in down county and created a mobile team down county and then one up county, so that we could have daytime and evening response capacity, which are the highest utilization periods in the day, in any given day, down in those regions, to get us out the door faster, and also to build connections with the community members that were there in those areas. So that was the second change that came as a result of the resources that we were given. The third thing, I think, is the civilian response capacity, which really got started this past July. It was a process of training folks and getting them oriented to a different kind of response model. And you've heard some of the numbers. I would say that we have hard data on 25% of our responses since July have been civilian responses. I don't know about the other pieces of data that you're asking about, and I think the team can follow up with MCPD to get a little clearer about that. Someone asked the question about why MCOT and police are responding together. It's a 20-plus year history, and the model has always been police and crisis responding together. That change is going to be slow. It's a cultural change we're making here, because the team had some concerns and anxieties. As someone who's built crisis response teams that responded independently, I'm not concerned about it, but I'm mindful that between our union staff and our members of the department who had a particular way of responding, learning something new is something we need to move carefully and judiciously on. Having people learn what's safe and what's not safe, and how to protect themselves and how to respond differentially is an important piece of this process. But I do think that there is some advantage to responding with a civilian team, that it automatically de-escalates a situation before it has a chance to ramp up because of law enforcement being present and what that might do to someone who's in the middle of a psychiatric crisis. We modeled some of this off of Cahoots, and indeed we did a contract with Cahoots. We retained them as a consultant for us for several months to look at our model, to look at what we were doing, how it compares to what they're doing, what their experience with the client population is, and some of the changes and the pieces, some of the way in which we've evolved is based on direct feedback from them about what's different and what's similar between how Cahoots responds and the volume and types of service issues that we see in the county. One of the things being is that they do some upfront assessment about the level of severity and the risk associated before Cahoots is called out. And part of our call center collaboration that I think Dr. Santiago and the team will talk about does some of that work and is built off of some of that work, so that we're benefiting from their model as we go forward around this. We've changed the ways, changed how we train staff to intensify their training along the way, and we strengthened our communications and coordination protocols with 988, 311, the Crisis Center, 911, Police and Fire and Rescue, just to make sure that we are doing a tighter job of coordinating those services across the various units. The other significant change is the increase in our use of peer support specialists and peer recovery specialists. We've had several programs in the county that do outreach and engagement with community members as part of the county's and the HHS overall response protocol. We've now added that to the crisis response, to our mobile crisis outreach teams. They are capable of doing a lot But one of the things they're definitely capable of is in a crisis helping to stabilize, to de-escalate someone because of their lived experience and because they have had, with training, skills to add to that mix. We are looking at, I think, to continue that inclusion of people with lived experience in our response. And I would say, just as a side, that peer recovery and peer support is growing across the entire department. The other thing that has changed in the last 2 years is stronger collaboration with partners in both public and private sectors. We hired Dr. Santiago during the middle of the pandemic, and it was almost a year before I saw him in person, actually. But one of the things that has happened is that one of the things that he took on immediately was creating 3 groups that are part of, that are core to implementing the Crisis Now model in Montgomery County. The first one was the call center work group to deal with all those various places call centers that we historically have that operate in the county. People know call 911, they know call 311. Some people who are more sophisticated know call the crisis center. Some folks call our crisis hotline with Every Mind, and increasingly folks will be calling 988. That's 5 different potential numbers. We need to integrate those numbers so that people, no matter where people call, they get to where they need to be. Maybe over time there will be one number, I don't know, but for now that's where we are. And so we're starting where we are, moving to make sure we can coordinate across those different lines. The second work group was the crisis outreach team that was designed to work, that includes CIT from the police department, includes our Montgomery County Fire and Rescue teams and their outreach effort. It includes STEER, that is focused on addictions, and it includes our homeless outreach programs. So there is more going on here than mobile crisis outreach and CIT, and coordinating that is an important piece of this work. The third one the Stabilization Facilities Work Group, and that includes our work with General Services, Montgomery County Police Department, Fire and Rescue, and the hospitals around doing work that diverts people from either jail or unnecessary and lengthy stays in the emergency departments. Restoration Center is the piece that you will know, you'll be most familiar with that. But there are also crisis stabilization units, including crisis beds at Picard at the Crisis Center that are part of that process. And that raises a sixth important point, and that is that we have funding now for the Restoration Center, a $17 million award from Maryland Legislature in the 2022 legislative session has given us the funding we need to build that space that will have recliners and beds, help stabilize folks over 24 to 72 hours, but we'll also have a team of folks that are designed to make sure that they are connected to what they need beyond that moment. And then lastly, because this is there are a lot of players and a lot of moving parts, we created a leadership collaborative at the end of 2021 that consists of all those players that I've mentioned: Fire and Rescue, the Police Department, myself, members of HHS teams, the Nexus Montgomery teams, hospital representation, the Mental Health Advisory Committee, and AODAC to come to the table to talk about what crisis response looks like, both in the immediate emergent conditions in which we respond, but also in the aftermath, what happens afterwards. And that group is now very much focused on trying to understand data and what constitutes success in this overall model. I'm going to pass this over to Dr. Santiago, but I do want to say that crisis response is our first contact, and it's important to consider and understand what comes next. We've done a lot of work to expand this. I expect that there will be more in the future, but one of the things that happens is if the front door encounters a bottleneck where there's insufficient resources and supports, then you get a recycling process. You work with people, you release them back in the community, let them go back to the community, and they cycle back. So we've got to be sure that as we build any piece of this, that we're thinking from front end to back end about what else needs to happen. We don't do this work alone. Drug court, mental health court, the Public Defender's Office, the State's Attorney's Office, Department of Corrections, hospitals, our addiction treatment providers. There's overlap with overdose intervention team in this work, and coordination across all of those services is a part of what has to happen for Montgomery County. I think the thing that I would leave you with is that we sit in HHS and crisis response, the Crisis Center sits in HHS, and mobile crisis sits in HHS. Some of our peers do as well. And the advantage of that is that they're connected. They're connected to housing, they're connected to our financial resources, they're connected to our health system in ways that they might not be in other systems. So with that, I want to thank you all, and I will turn this over to Dr. Santiago to take us forward.
Okay. Thank you again for the opportunity to be here, and thank you, Councilmember Ledke, for chairing.
You have to hit the button.
I'm sorry, I should have reminded you. There you go.
Okay. Thank you, Councilmember Ledke, for taking on this role of being the lead in crisis response. We really appreciate tremendously the background that you bring and also the passion in this area. And we really look forward to having you ride along with the MCOT team at some point. We did that about 1.5 years ago with Rebecca Tan from the Washington Post. And we should get you the article that she wrote based on that. It was quite a moving story that she was able to tell. I think of 2 different responses that she was able to observe, and I would think that that's probably what you will experience as well. So thank you again. I'm going to go through the PowerPoint, and I may go a little bit quicker because Dr. Kroll covered a lot of points, and I think what we want is a chance to dialogue as well. So forgive me if I sound like I'm going through these very fast, but I value a lot the feedback that we can get from you. I have my partners in crime here, Beth Tabachnik and Dornay Hill. There's probably not a single day that we interact in some way or another on these issues, and I'm really appreciative. And I did want to say that part of my experience, even though I started October 2020 during the pandemic, has been the incredible relationship with law enforcement and with the police department, starting from Chief Jones to Captain Satinsky more recently, and also with Chad Matthews. And I appreciate tremendously the vision that they're bringing and the energy and the excitement that they bring to the table. So we feel really honored. I think I can speak for all of us, honored to work with them on any improvements that we can make, and we look forward to them. So I'm going to mention some of the challenges. We saw that the pandemic exacerbated the need for a robust emergency response. That's the first slide. Yeah, there we go. So we knew the pandemic exacerbated, and we saw it. We saw that it exacerbated the need for a robust emergency response, and we saw it in the numbers. So Dr. Kroll already mentioned the increase from 2020 to 2021, from 495 to 979 responses of the mobile crisis team. At the same time, I want to recognize fire and rescue services have shared with us on an ongoing basis. They respond to many more that are behavioral health related. So for example, during that same period, 2020, in 2020, they responded to 10,471. In 2021, it was 13,377. And I've interacted with my other partner at Avital Graves about getting the 2022 statistics. But you can see that these responses show that the need is there, and it probably means that the need is increasing, and the pandemic had an effect on that. We also see a gap in crisis response and stabilization services. We know that there's an insufficient number of mobile crisis and outreach teams based on an RI International report that we received actually in 2020 as well. In that report, they estimated that we would need 8 teams, MCOT teams, to respond to the need. Right now, we're able to do 3, Mondays through Fridays on day and evening shifts. The other lack of services right now is a lack of short-term 24-hour to 72-hour stabilization services. So where are they ending up? These individuals, they're ending up in the emergency rooms and sometimes in jail as well, because we do not have a specialized behavioral health response. I just heard that Arlington, Virginia is doing a hospital of 100 beds, and we're talking about 45. So there is an immediate need to get this $17 million funded project on the go. And I'll speak a little bit more to that in a moment. The opportunities are in developing the behavioral health crisis response in Montgomery County is that we have a model. We have a national model, the Crisis Now model that Dr. Kroll mentioned. And that model has 4 components. The integrated crisis call centers that would move us toward one regional air traffic control number that we could use. Some say that maybe 988 will become that. We don't know yet, but it's moving in that direction. The statistics are good on that since it started in July 16 of this year. The second component is the mobile crisis and outreach teams, which we've been speaking about. The third one is stabilization facilities, restoration center, and then the crisis care follow-up. What do we do after we stabilize these individuals? That is as important as well, building up the capacity of the system to then take, I think you referred to only 20 beds in the whole state for youth, adolescents. Absolutely. So that's a good example of the kind of building up of the crisis care follow-up system that we need to be doing. Another opportunity, the goals here are to divert people experiencing a behavioral health crisis from landing in jail or in a hospital emergency room, respond equitably. We have Montgomery County, as you know, is one of the 10 top diverse counties, not in Maryland, in the country. So we need to respond equitably. We need to be engaging the community. I can tell you many stories about engaging with the community in my role. And we also need to promote the well-being and achieve public safety for our residents. And that's why we're here, right? HHS, public safety, together, because we believe that public health may have a response to public safety as well. We're trying to do it together. The model we're using in Montgomery County, as Dr. Kroll mentioned, is borrowing from the Cahoots model, which Councilmember Mink has mentioned a number of times in her questions, and also the Asante model from Toronto, Canada, that they emphasize more the peer involvement, which is what we're also moving toward. Specifically in the integrated call centers, Dr. Kroll already mentioned the work group that meets every 6 weeks faithfully. And maybe the last project I will mention about 988 director, the director of the Emergency Communication Center, 911, the director of 311. Believe it or not, we get quite a number of calls from 311 as well. And those that come directly into the 240, 777-4000, our crisis hotline. We're collaborating. Our latest project is actually to do a graphic that shows what the function of 988 is, what the function of 911 is, what the function of crisis hotline is, and what the function of 311 is. And that's going to be for the public. And listening to this conversation, we're going to do it in the 6 common languages of Montgomery County. And it's a very simple, it's just a simple graphic that will describe how people can access and who should they call for what kind of problem they may be experiencing. So we're very excited about that. That's our latest project in that work group. Here's some numbers that we've been starting to collect from each of them. These are warm handoffs from 988 over from October to December. So these are recent numbers. The Crisis Center has received 117 warm handoffs from 988, 44 from 911, and 78 from 311 for a total of 239 warm handoffs. So we're documenting that. That's also a project of that work group. Then we have the second work group, which is the mobile crisis and outreach teams. We've been convening again since 2020. This work group meets every 6 weeks. It includes the police department, Department of Health and Human Services, Fire and Rescue Services, and they advise on the expansion and policies for the MCOTs. We also, as we've already talked about, have been expanding our crisis center staff from 24 to 30 staff at the crisis center, thanks to funding, special appropriations that we got from the council, and we got additional funds. We have an additional 14 staff that we're expecting to hire. 8 of them are county positions and 6 from federal grant positions. So we hope to build from 30 to 44 once we hire all of those. That will be significant. We're also increasing the MCOT teams, how many, and the location. And Dr. Kroll already mentioned, we have an up county in Germantown where we can dispatch the mobile crisis team, and one in Silver Spring, not far from Progress Place. And my understanding is already they sometimes respond to Progress Place incidents as well. Here are some numbers. I think you have become very familiar from listening to you, Councilmember Lutke, with these numbers. My apologies on the unknown. This is new record keeping for us. We're trying to resolve those unknowns, but I expect that actually the civilian responses are a little higher. When we really inspect the unknowns, it's going to be higher than the 25%. So some of the supervisors say maybe 30 to 40% might be a more accurate number. But we did want to show some data. This is, again, new data that we've been starting to collect. We also are the future in terms of the civilian response is that we're adding a peer support specialist to a 2-member team. So now they're deploying, as of this month, we're starting to deploy them with a licensed clinician therapist. So that's completely new. I mean, they've been in training for about 6 to 9 months. They've received considerable training. They've been doing a lot of tasks there at the crisis center. I hear stories that the supervisors are amazed at how knowledgeable they are with a recovery system and how they can connect even with the walk-ins in suggesting where a particular walk-in person can connect to a recovery program. And they just have it in there. They just know it. So we're being able already to use their lived experience in a very effective way. Also, the future of co-response with police is moving I don't have to say much more because I think the CIT team covered what the vision is, and we're right there with them. I'm hoping that on Thursday, we're going to have a follow-up, a debriefing from this session and continue our conversation. Where can we do it? How are we going to hire? Get all the details and the kinks out of the way. In terms of the expansion or the way we were able to begin on July 25, the civilian response is because Cahoots staff helped us to develop a common triage and dispatch protocol. It took months for us to negotiate with our staff so they, as someone mentioned, I think it was Dr. Kroll, that for them to feel comfortable going without police presence. We did all of that. We developed protocols with the police department, and thank you to the police department. In one call, I had 3 assistant chiefs helping us develop that protocol, plus the emergency communications director. It's a very simple protocol. It just says, if there is a risk of violence, we continue to co-respond with the police department, whether it's the CIT team or whether it's a police officer on patrol, which we've done for over 20 years. So that continues. What is new is that now some of our teams go on their own without having to call police. Now, the reason the protocol says if there's no indication, there's no weapons, there's no history of violence over the last 12 months, there's no indication they should feel free. Now, what is interesting, and this became a aha moment for me in talking with Anne Arundel staff, is that we realized that over the last 20 years, the acuity levels of the individuals that we have been responding to are probably at the highest level, maybe in the entire country. Why? Because usually if the police is alerting us that there is a problem, it's probably because there is risk of violence. We got to de-escalate. So they may be the ones that first alert us to, or we become alerted first because a call comes in. We call the police, a police officer. We're there. We got to figure out how on the response times, how to do it in a quicker way. However, the strength of the model has been that we have been responding to some of the highest acuity level individuals. Think about it. How many fatalities might we have avoided with all the responses we've been done over 20 years? Sometimes we don't think, Jen Corbin mentioned, we don't think of the positives, right? Because they're hard to document. But how many fatalities might we have prevented from occurring? So that's why I'm so proud, and I talk passionately about our work together with the police department as well. This is a protocol. I won't go into the details, but we can send you a copy. It's in the packet. So, in fact, I think it's twice in the packet. So, but the response, the mobile response, it's not just these teams. I want to recognize also the homeless outreach teams. There's quite a number of them, 14 outreach-related staff. Those are coordinated through the Services to End and Prevent Homelessness. Amanda Harris is a chief. There's also the crisis intervention team that you heard about, and they desire to expand. We affirm that. We want to be partners with them. And then, I don't know if Avital is still here. Yeah, there you go. There's Avital, the director of the Mobile Integrated Health. Did I get it right? Yes. Mobile Integrated Health Team. It's an exciting team, and she's building it up. She's getting more funding, right? Yep. So more social workers. So it's not just the MCOTs, it's also the CIT team. It's also the Mobile Integrated Health Team. We have great resources. These are the groups that are coordinating, and that every 6 weeks that I mentioned, we talk to each other. Actually, I'm going to go in a rabbit hole, but I need to say this. Avital also chairs a group that is focusing on maybe the top 20, maybe not even that many. Smaller group of people. They call them the high utilizers, the frequent flyers, if you will. And they're collaborating. They have staff from the crisis center, from the hospitals, and I think even the CIT team, and they're concentrating on those few, maybe 10, 12, 15 individuals that consume a lot of our resources. So we're very, very proud, and thank you, Avital, for doing that kind of work. Stabilization facilities, in addition to constructing the restoration center that I mentioned a little bit ago, for which we have funds. We just need to finalize the location. We need the approval. We're working together with Rockville City. They're becoming increasingly our partners and agreeing that at 7 Lux Road is where we need that restoration center. We also are doing a stabilization room in the crisis center. Thank you to some SAMHSA grants that we have received, and we should be opening them soon. Now, our constraint has been, we've had this funding for about 1.5 years, and we can't get therapists. So what we decided to do is, can we do it without therapists? Can we use nurses, case managers, and also navigators? And that's where we're going. And right now, it's very possible that by the end of February, maybe more in March, we might be able to stand this 24/7 location. That's on top of the residential crisis services beds that we've had for many years. There are 4 beds for individuals who stabilize for 10 days. So that's a little longer term. 10 days allows for a little bit more of resourcing for these individuals. This stabilization room will have 4 recliners and for less than 24 hours. So it's almost a little bit like respite for them and getting them connected to services. So what are the opportunities in terms of crisis care follow-up? I need to talk about the walk-ins, which is a tremendous service at the crisis center for many years. These are the numbers over the last 3 years, 4,669. You saw during the pandemic year a dip, 3,730, but you recall that I mentioned that was the tremendous increase we had in mobile crisis response, 98%. So they became busy going to the field, if you will. And then we have this transition to post-pandemic year with 5,869, and they're continuously busy. So the future, we want to add navigators, care coordinators. I know, Councilmember Ledke, that you care a lot about a care coordination function. We're with you. We want to improve and work on that with you. We're hiring. We already have started to hire navigators, case managers. We're getting our feet wet. We know what it looks like to call someone 6 months after, but not just 6 months, a month after they were there. So that's going to be our practice going forward. We're just building it up, and we'd like to talk more to you about it. And we're building a robust continuum of care to prevent the recycling through the crisis response model. Increase in residential crisis and residential long-term beds. We need them. Outpatient services, case management, respite care, many, many other services. Finally, the vision revisited. We want to respond rapidly and effectively to crisis. We want to de-escalate situations at risk for harm of self and others. We want to respond to persons in crisis at highest acuity levels for preventing fatality, including overdose death and suicide, making crisis response accessible, equitably, culturally, and linguistically appropriate for a highly diverse population, and promoting the well-being and public safety of our residents in Montgomery County. So thank you. I don't know if my partners would like to add anything.
Hi, Dorney Hill, Senior Administrator, Crisis Intake and Trauma Services. I did want to say a few things. I was in my seat burning from some of the questions earlier. So the Cahoots model is a part of what we do. What?
No, if our tech folks might be able to switch off from the presentation that just ended, or there you go. Thank you.
So, sure. So the Cahoots model is a portion of what we do. It helps with the triage. The Cahoots model is not the totality of the work and the framework of what our clinicians do on mobile crisis. We have, we're trained in crisis intervention debriefing. We're trained in crisis assessment, biopsychosocial assessments. We do dual diagnosis. So we look at all of the social determinants of what is happening. We also look at mental health, substance abuse, misuse, and history of all of those things. So I wanted just to be clear that Cahoots is not, that doesn't technically fit our model, but parts of it did, and we incorporated those pieces to benefit the service delivery that we have. Because a lot of the work that Cahoots does is what our homeless outreach services does under SEF. So the way that we've incorporated that is that we do a lot of co-response with our homeless outreach providers, especially in the Silver Spring district, where they go out and they're on the scene and they call for us and we respond, or we're out in the scene and we call for them. And we do a warm handoff actually with the client in the community, so that there's no gap. There's not just a form that we're filling out and we're sending. We're really trying to do more warm handoffs in that respect. Was there something? Oh, and so also just the CIT versus mobile crisis outreach teams. I just wanted to make that distinction because I think there's some blurring of here in Montgomery County of what they are. So the crisis intervention teams are within the police department. There are therapists that are HHS therapists that sit in CIT. So Ms. Savashnik was one before she got promoted to this position. So that position is currently vacant. We also have another position that's newly created that we're hiring for in Rockville City Police for a CIT therapist. And we also have an MOU for 2 therapists with Tacoma Park Police to have for their CIT team as well. So we totally have started the work. We know that 1 and 2 is not enough therapists, but those have been in the works for over, well, best positions has been in play for over 5 years, but the other positions are new within the last year. So we're excited, and we definitely believe that having those CIT therapists there with the police department is a benefit for us and for them. But the mobile crisis team from the crisis center, which are HHS employees, consist of licensed independent therapists. We have some case managers, behavioral health technicians. They are folks that have degrees in other things, but have been trained to do crisis work. And then we now have our new peers. And that bulk of staff also see the walk-in services at the crisis center. And our walk-in services are not just mental health and substance abuse. It's also intimate partner violence, victims of crime, as well as homeless individuals. And then after hours, we also do child protective service calls, adult protective services, and public health. So though that same core of staff do all the different functions of the crisis center, including the residential crisis services, which is the 4 beds that are that he spoke of, that the average stay is 10 to 20 days. So I did want to just signify all of those differences. So culturally, we have therapists that speak over 8 languages on our staff. Between our peers and our clinicians, we definitely play musical chairs. One of the first things that we ask when we're taking in a mobile crisis call is language, culture, who's in the home, what, is there already a therapist involved? Is there, another facility or an entity involved? And we try to get all of that in place so that when we're going, we have the right language, we have the right players in place so that we can have the best intervention possible. If we don't have that, we do have a, what do you call it? The video interpretation. So there's actually a person that we can pull up on our tablets and phones. And we also do have the phone language line that you can call in. We find that the actual person, we started that during the pandemic, is a much better intervention so that the client can actually see somebody. It's more intimate than just having a phone. So we've definitely tried to address that. So just want to throw that out there.
And I know that with 988 and its initial rollout, the use of the text function on 988 has been a big deal. So, of course, with the text function too, there may be language barriers that are unique to Montgomery County, or maybe also Howard County, but maybe aren't as experienced in other parts of the state that we really need to make sure we are addressing here so that we have adequate support within our answering points. So I know, thank you, Dr. Santiago, for talking about the center that's about to open and the distinctions between the types of interventions that you can have and how long you can stay. I had pulled some statistics from the state related to Montgomery County. So in fiscal year 2019, we had 70 acute psychiatric beds licensed to operate in Montgomery County. And then in fiscal year 2023, we now have 187 licensed acute psychiatric beds in Montgomery County hospitals. But in fiscal year 2019, when we only had 70 beds, the usage was 19,673 patient days, which, if you do the math, translates to 59 years worth of treatment in those 70 acute care psychiatric beds that we had here in the county. And that is just staggering when you think about it and think about the need. And of course, everyone's preference would be not to have to be in an acute care setting, not to have to be in an emergency room either, right? These are the beds that were available. We're not even talking about those for whom they could not get a bed and they were, essentially boarded in the emergency room, which is an epidemic statewide. But one of my questions, and Dr. Santiago raised this, is the coordination of care aspect. We're a large county and an incredibly diverse county, both in residential makeup and in our geography as a whole, right? So even with the transportation options we do have within the county, not everybody can get to Rockville, and not everybody, has the ability, especially if you're in a situation where you're going to require ongoing care, to manage that themselves. And of course, we have a lot of great, wonderful nonprofit partners who provide community-connected services out in different aspects of the county. But it seems to me, and maybe I'm wrong, and I know you said you'd like to talk about this further, but that one of the incredibly missing resources or needs we have is to help all these different pieces that are doing good work function better together. And bridge that gap, and bridge both an information gap, and you all are doing amazing collaborative work, right? And thank you, Avital, for your work on our frequent flyers, because that does need a higher level of attention because it is incredibly resource intensive, and those divert from other folks who are going to need assistance. But what can we up here, policymakers, do to help you in getting to that care coordination that the county needs across the board, so that we are, decreasing repeat, increasing prevention and intervention, and reducing higher risk calls?
Yeah. May I respond? One element of this, I mentioned the navigators, and this has been actually a passion of Dr. Kroll in the Department of Health and Human Services. So over the last 2 or 3 years, he can probably speak a little bit more than I can on the role of navigators in beginning that process of care coordination. And that's something that we're doing at the Crisis Center. We've already started with some navigators, but perhaps you can
Sure.
share a
So
little.
one of the things that I set in motion when I started as director was about access and navigation, and an effective and culturally appropriate workforce. We're three of the four priorities that I set in place. But the access and navigation pieces are the pieces that you're talking about now, and that is how do we manage to make this easy and seamless for folks who need our help. And one of the things that's true about HHS that you all will find is that we are enormously complicated. No matter how complicated you think we are today, in a year, you will have a different sense of this. And for people coming in, they need to have someone who works with them. And so we've identified navigators in the department. We are also out stationing navigators in key places, up county, down county, and partnering with the hubs that were created during the pandemic to make sure that there are people in those places that can say to them, you're here for food or you're here for some other resources, but there are other things you need. And there's a person from HHS who's a navigator who will be here at this time on this date to help you get to where you need to go. So we're trying to do that work. We have a variety of providers that are regional that we're working with to try to make sure that if you're in that community, if you're from a particular community, we can help you connect to the resources that are in that community if that's what you need. HHS is complicated and human services is enormously complicated. on the behavioral health side, about, the last time I looked at the numbers, about 40% of the services that are behavioral health services are provided through contract partners. And so we have a variety of partners doing everything from transportation to case management and care coordination. And we use those partners, we're in constant communication with those partners to try to make sure that we facilitate connections with folks. Not perfect, far from it. In fact, I think that because there's so much of us, that it's impossible for any one place or any one organization to know where to reach out to. But the 311 coordination, the call center coordination that you've talked about, that you've heard us talk about, is a part of that integration effort. So to make sure that when 311 gets a call, they know that they can, how to get it to where that person needs to go in the system. So in HHS and with other providers across the network.
And just very briefly, Councilmember Katz mentioned earlier mental health court and drug court. I've observed them in function, and you can't find a better model of care coordination than in mental health and drug court. And the outcomes are just incredible. So we have locations where care coordination is happening in a very, very good way. Can we expand it, make sure that for the population, we're talking about the population of individuals in crisis response today. So how can we build further care coordination in that model? But we do have great examples, as Councilmember Katz pointed out earlier. He was instrumental in founding those.
One of the things I would note about the Crisis Center is that after hours, after 311 closes down, after our various programs at the department close down, the Crisis Center becomes HHS and sometimes becomes Montgomery County. We calls for dead birds and roadkill, all kinds of things that end up in front of the Crisis Center. The Crisis Center deals with.
Or people hanging from electrical.
People hanging from planes, electrical. Exactly. So it is that team has gotten very efficient at figuring out how to triage and how to connect people up to. It's one of their strengths, I think.
I definitely was very interested in mapping across the state which counties did have diversion courts and which ones did not, because not everybody does. And for example, Western Maryland in mobile crisis, they have one mobile crisis unit that covers Washington County out to Garrett County. And if you haven't driven out there in a while, or you've never been out there, they are not near one another. They are nowhere near one another. It's hours of drive and no public transit. So, very, very important pieces here to talk about. And I believe we have, Sydney had asked first, and then we will have Councilmember Meek and Councilmember Albornoz, and then Councilmember Sales. Okay.
Thank you, and I will be, because of the hour, I'm going to be a little faster. But first off, again, thank you all for doing what you're doing. And Raymond, we certainly are going to miss you. You're already missed, I guess, at this point. But I did think it should be noted that Ms. Hill did say that you're playing musical chairs, and Dr. Santiago, you started playing music a couple times already. So we do appreciate that. Or the beds that Councilmember Lukey was talking about, are they private and public, or are they just private? How does that work?
Specifically, the crisis center, those 10 days of crisis beds.
I'm talking about the hospitals.
Oh, hospital. Yeah, they're primarily private, I would say.
So they're primarily private in the county. There are a couple of state hospitals that have psychiatric bed capacity, but that has shrunk tremendously over the 30 years of my career to its current levels. So
what happens if someone doesn't have insurance for those beds?
No.
Say again? I'm sorry.
So Beth and I both we work intimately at the hospitals and have worked in that capacity. They still get a bed. The state will authorize that. It's just like no one can be turned away for not having insurance. There are some private hospitals who won't take clients without insurance, but there are some who will. And Medicaid can do some authorizations for people who are uninsured. But they should always get a bed, but there are some hospitals who won't.
So and I'll ask as one last question. How often do you think a non-police person, a social worker or whatever, feels unsafe going into a situation without a police officer?
We'll have that.
They turn to you right away. They look right at you. Yeah.
And I'm cognizant of time, but I'm passionate about this topic. I'm newly promoted into this role, but I've worked in crisis services in the county for 20 years. I'm uniquely I've been the only person in the position co-located with the police department. So I'm very passionate about crisis response and all its permutations. And I want to take this opportunity to just express my gratitude to the Crisis Center staff and the staff of HHS for being so committed to this work, for being so front-facing during the pandemic, during the public health crisis, and for continuing to work with our ever-changing and ever-expanding system. They are the heart of HHS, and we couldn't be more appreciative for them. So the answer to your question really is it depends. Crisis situations, there's really no cookie cutter to them. It runs the gamut of every possible scenario you could possibly imagine. And so there are situations where absolutely, and our staff have really adapted to this request in terms of reduced use of law enforcement. There have always been situations that were lower acuity that our staff felt comfortable responding to without the police. But one of the gaps in our data, the 25% that's a little bit unknown, has been we've had to change our data collection points as we've moved through this or moved further into this protocol, because we realized that we weren't capturing data initially on when our teams went out without the police initially. They did not request a law enforcement response initially, and then they did ultimately request that the police responded to the situation because the individual had escalated. It was more, the situation was not quite what it seemed, or they did have to initiate an emergency evaluation petition, which is where the officers will assist with facilitating transport to the emergency room. So within that 25%, I think some of those numbers fall, and we have started to capture the data of when we've responded now initially without the police, but have later requested them. And so I think if we were to have this conversation, 6 months from now, a year from now, our data would look a lot cleaner to you, but we just don't have that data yet. So the answer to your question is there are absolutely situations where clinicians would feel comfortable responding without the police, but sometimes these situations are really unpredictable, and it's really hard to know going into a situation what's going to transpire. And then there are situations where absolutely we would not want our clinicians going into these calls without some sort of safety presence because the variables are so acute and so concerning. And I will say, as the clinician assigned to the crisis intervention team with the police department, there were situations. I mean, these situations aren't cookie cutter. There were situations where I would go in, and the individual wasn't interested in speaking to me as a clinician, but the officers actually were able to develop a stronger rapport because, for whatever reason, the individual didn't see the situation initially as a mental health issue. They saw that they wanted support from law enforcement for other reasons, but they didn't necessarily feel that there was a mental health component. And then I was able to engage them and develop a rapport with them, and we were able to connect them with services. So unfortunately, I don't have a clean answer to your question, but it's
an individual.
It's variable.
But I was just wondering percentages.
And it's very unpredictable.
And I did want to point out one last thing, literally, but you mentioned that I was involved in bringing mental health courts, and I was, and I'm very proud of that. But if it weren't for HHS, if it weren't for the state's attorney, if it weren't for the judges, if this team wasn't there, and of course it's the state agencies to start with, it would have never happened. It's just amazing how fortunate everything came together in order to get the best life that we could get. So thank you very much.
Councilmember Mink.
Thank you. So related to what we were just discussing, how are we analyzing if our assessment of potential for violence is accurate? 50% of calls seems like a lot, and I know that Dr. Kroll mentioned that part of it is that we are embarking on a cultural shift, and that takes time. So So how are we assessing whether we're in the right place? How will we know when we land at the right place? How are we working to improve the accuracy?
I think the cultural shift is part of it. I'm going to jump in and please, please jump in as well. I think the cultural shift is part of it. I think the other thing that we're facing currently is that, one of the things that we can't sort of underemphasize enough is that within the past 3 years, we have seen, we've attempted to create these changes in the midst of a global health crisis and one, in a pandemic that has impacted our community and impacted the mental health of every single, person in our community, either because of, their own experience or someone they know. And so during this, during the past few years, we have had reduced access to mental health services. We've had reduced socialization. We've had reduced everything that creates a healthy, well individual. And so, so what we're tasked with are, not only do we have a higher volume of requests, but they are at the higher acuity level at a point where we're facing staffing shortages at a national level. So so in terms of that 50%, I think what we're looking at is that we have an increased number of highly acute situations. When we're triaging, we're responding to the situations where there are safety components. Those are the situations that we triage in terms of priority response, and there are many of them. Many of them. We see the impact of not responding as well. So to answer your question, I think as we even out over, my expectation, and please jump in, my expectation would be that we will see these numbers even out, both because our staff are adapting to the new protocols, but also because we're seeing a stabilization of the mental health system, the behavioral health system across the board as we come out of the pandemic, and there's increased access to mental health services, and not just for uninsured or state insured or federally insured, but for all residents of Montgomery County. I know, even for folks who are very well resourced, they also are facing these same difficulty accessing mental health services. This is across the board throughout nationally, statewide, and locally here in Montgomery County. We're not immune. So I think as we see this even out, we'll see our numbers, I think, more in line with probably what your expectations will be.
Thank you for that. And a follow-up question, so do we have any kind of quantitative or qualitative method of analyzing our outcomes to know when we hit the right number, whether we could be going lower? This is especially critical given our staffing shortages and making sure we're using our people and our resources in the right way. How are we going to know when maybe 50% is the right, or it sounds like it's likely that it's going to go down, which I think makes sense looking at other numbers, but how are we going to know when we reach the right number? How do we know that we want Montgomery County to be a leader, right? How do we know when we've reached the best use of resources that we possibly can and best serving our community? Yeah.
So I'll respond to that by going to that RI International report. I don't have the precise statistics in front of me, but I have them in my mind. It's over 10,000 needs for crisis response that are unmet right now. In order to meet those 10,000 or so crisis response, we would need 8 teams, and right now we are at 3. So there's a lot more building up that we need to do. I can give you a longer answer, but I'll just stop there.
I'm just curious, was your question about our capacity for crisis response, or the balance between civilian and non-civilian? Civilian officer. So the one thing I would say is that I know that the team is part of our protocol for ramping this up, is looking at the calls when they come back in to do a debrief to understand, was this a call that we could have responded to without law enforcement, or one that we really should have responded to with law enforcement, so that collectively we get sharper and clearer at how to make those judgment calls when those calls come through the door, when they come through the phone lines for us. The team does a very good job of evaluating the histories, both psychiatric histories and risk of dangerousness. They will get better at that over time, and so those numbers will start to drop, and the civilian responses will continue to rise, subject to the things that I think Beth has talked about. We are in a mental health crisis, and if my experience with Katrina and other smaller crises is any indicator, we're going to be seeing the impacts of the pandemic for a number of years, and to the extent that our provider network isn't available, people will bump along until they hit a crisis point, and then we will see them. And that's the challenge we're going to be facing. So it's early to begin to predict what those numbers are going to look like. But our goal is to continue to drive that number towards more civilian responses, bearing in mind that the safety of the people who are involved, including our staff, is paramount. We have to make sure that they feel comfortable and that they're safe, as well as the clients and individuals that we're responding to.
But I hear your question, and that's a note that Beth and I will take back. We do have a new data manager with HHS, and we have a data management team that's new. So we are trying to really flush out how to capture what we want to capture and how do we capture it within our system or by hand. Hopefully not by hand, but really looking at, what we're looking at. So we will definitely take note of that, and hopefully our next session will have some answers.
Great, that's helpful. It's great to hear those conversations are taking place. And so, in the content of those conversations, is there a way that can be reflected in data, right? Is there a way that we can be improving our analysis and also so that we on the council, as we're decision making, we are not in the room with you, so we have ways of understanding how we should best be making those decisions. Let's see, are we also tracking the numbers of calls where either MCOT was initially requested but did not end up responding, whether that was for staffing reasons, time of response, or another reason, as well as the number of calls for which MCOT was assessed as the ideal response, either with or without a co-response, and then ended up not responding again for whatever the reason might be?
So that is a yes, but that's one of the data points that we're collecting by hand right now. We are moving to a new electronic health system, health record, that will have a more robust crisis call line, so that we're able to capture those types of data points. So again, hopefully by the time we come back, we'll have more data on that. But that is something that we're capturing a little bit right now.
I think we should mention that we're working with a county, with TEBS, with respect to changing our phones. We have an antiquated landline-based phone system. Mm-hmm. We need a cloud-based phone system, and that's what we're working with TEBS on. And that will allow us to capture more data about the calls, similar to what 911 does. Also 988, they have also sophisticated software to know where the calls are coming from and that kind of thing. So we're building up that capacity.
Thank you. And I know I'm sensitive to time. I have two questions that I'm going to be quick about, and if we want to follow up in the conversation afterwards, that is fine. But I will just note the questions. On the graphic that's provided, it shows that when MCOTs and police co-respond, MCOT arrives first and waits for officers to arrive for a co-response. So interested in numbers about how often that happens, and also curious about what happens when police get to the scene first. Do they also wait then for MCOTs to arrive? And then my other question is just trying to better understand why CIT includes counselors and handling the follow-up response and things of that nature, as opposed to that falling under MCOT and then HHS caseworker. It seems like we're splitting similar capacities in different places. So I don't know if you want to briefly speak to those and follow up later.
To that last question, it probably it's more appropriate for the police department to answer the second question on CIT. But we've worked plenty with them over many years, and I know that they really want to engage the community, and I think it's that impulse that is creating the desire to staff up, if you will, the CIT team. And it's, I don't know if it got through that police usually may be the first responders to arrive. That followed by EMTs. I mentioned the 13,000, but the police department answers many more than that. We don't have a precise number, but Captain Satinsky mentioned that he's working with a ECC on getting more better documentation about that. And then we are just under 1,000. So you can see who are the first responders that are dealing with behavioral health. It's always the police. They have the cars, they have the infrastructure, right, to be at the scene. However, we're moving in the direction. This is culture and systemic change in Montgomery County and across the nation. We're moving towards more of a civilian response, which means that resources need to go more into behavior. And I think that's the line of questions that you're asking, and we're with you. We're trying to figure it out. And if it means that for a time CIT needs to expand, there's plenty of need out there. We're not going to compete for the need. There's no doubt about it. So it's just another response that we have available, same as the mobile integrated health of the EMT, of the fire and rescue. So we have all these tools, and we're trying to keep them coordinated. I mentioned those phone calls that we do every 6 weeks. So we're trying our very best to keep the whole picture coordinated. And I hope that the outcome of this conversation will be, and I think that our legislative associates did a nice job towards the end of the packet. If you read it, they're suggesting let's look at perhaps a multi-year plan altogether, thinking in the same direction. What do we need to respond to all the needs?
That's helpful. Thank you. And to be clear, I don't want to set this up as a competition either. I think that we all want to be on the same team here. But it is up to us to really use a data-based approach to figure out what is the best way to serve the public. And then let's put our energy and our funding into that. And so, if there's not a great reason to do this, then we should do that. And it truly needs to be data-based, and it should be as streamlined as possible. Thank you.
All right, Councilmember Albornoz.
Thanks. Start out on a significantly lighter note, but Council President Glass is having a birthday party as we speak, so somebody please text to save us some cake. Back to the more sobering news here, and I've had the benefit of seeing the evolution of this program, and when we first applied for the Crisis Now application, and I just got to tell you, I'm very impressed with how far we've come, how hard you all have worked. This is not easy. To change and evolve in real time as we're addressing situations which we've all acknowledged can be complex and just life or death on all the way around. So I'm going to start there, which is sort of a sad place to start, but there's been a 40% increase in gun sales in Montgomery County in the last year and a half. And the advent of, because of what our Supreme Court has done, even in the state of Maryland, the sad reality is many more of our residents who don't feel safe for whatever reason are going to try to take matters into their own hand and purchase a firearm or get one illegally. So this is tough in terms of addressing situations, and all of them are very difficult. I know law enforcement had to leave, but is there a note that is taken? Is there information passed along if we know whether or not there is a firearm in the household that we are responding to?
So certainly, when we respond to calls, that's something that we would routinely inquire about, and we would keep documentation to that effect. One of the beauties of the partnership we've had with MCPD over the years, and one of the reasons I felt so lucky to develop that relationship when I was working closely with the police department is that we also partner in terms of triage, in terms of acquiring information that can help us triage our response to calls. And part of that's working with the police to see, do they have a registered firearm in the home? Have they purchased a firearm recently? We've had, they're able to access that information through the state database. And so for situations where there's a concern for safety, and we've had situations where we've been able to develop the safest possible approach to a situation based on information, that we gained from what the police had available to them that we might not have known otherwise.
I appreciate that. And related, so one of the great aspects of forming the team to apply for the Crisis Now was the really broad group of organizations and individuals, and MCPS was very much at the table. And I know continues to be. But in the sharing of information, in the world that we live in today, with the amount of firearms that are now becoming readily available, clearly closing the loop and having information to be able to share amongst each other is important to keep everyone safe. So could you talk a little bit about the partnership with our school system and our other youth providers and how they fit into this very important equation?
Yeah. With respect to the crisis response, we have had for many years a vigorous relationship with the schools, to the point that some school principals know exactly our number. They dial it and they use them. We've had 1,500 to up to 2,000 referrals from the schools to be assessed at the crisis center, and then once the child or the student is identified, the family is contacted, they come together to the crisis center for an assessment, and there's follow-up, and that's where I pass it on to my colleagues here in terms of what happens. But there has been a very strong relationship with MCPD, and we also deal with crisis. Sometimes I'm the one that's getting the call from a top official at MCPS on a particular very difficult situation that requires some degree of confidentiality. But we have a strong relationship, and we continue to build that. I can go on and on stories and initiatives with MCPS, but I'll stop there.
Councilmember Reynolds, just to say that as you, and you know this because of your history with us, that we've been talking about mobile crisis response situations, but you know that in the aftermath of an event in the schools, that our crisis team, various members of our crisis team respond, but also members of the HHS team across the board respond. Our Street Outreach Network responds. Our school health and wellness centers teams respond to try to do two things. One is to deal with the trauma of the event, but also to help de-escalate potential additional retaliatory behaviors of violence that could happen as a result of an incident.
If I could mention something else, I hope sometime you get to hear the story of the 6 months after the Plumgar incident. We had what I call a community de-escalation process. Community, and the reason I use the word community is because there were at least 4 families on both sides, on the perpetrator side as well as on the victim side, that had to be moved. We had to work with multiple agencies, MCPS, but also HOC, to find location. It was maybe in my 2 years in my here, it has been one of the most inspiring experiences that I've seen in terms of the care coordination that we did during that time. I know Dr. Kroll has said, write it up, this is a model. We need to do that, but it's another example of collaborating also with MCPS and other partners on community de-escalation.
Right, and Beth and I frequently meet with MCPS, the community outreach and crisis division. We meet with them sometimes weekly, minimum monthly, about not just for incidents, we also do community events for MCPS. We do education. We attend PTA meetings. We talk about prevention and promotion and how to really signs and symptoms look for your kids if they're staying in their room. You know, the opioid epidemic, what they might look like, what your kids might be saying. So we're trying to do some of that prevention and promotion, and that's been recent within the last year that we've started attending PTA meetings, different events, community events at community centers and rec departments to really try and get our faces out there and get our services out there before it's a crisis. So that's some of the partnership that we've been doing with MCPS and trying to be there in the moment so that people know us when they need us, but hopefully they'll know us before they need us.
I just want to point out there's so much room for improvement in this area, but I do want to point out that the partnership with MCPS is one area where we've been really successful, at least reducing overuse of emergency departments, because we've had this partnership with MCPS where we have a school referral protocol where they refer students who have indicated in some way, verbally or otherwise, that they might have thoughts of harming themselves or someone else. They refer the student with their parent or guardian to the crisis center for assessment. And over the past 20 years, at times the statistic has been almost infinitesimal, but on average, less than 5% 90% of those students referred to the crisis center end up being referred on to the emergency room for inpatient care. And so I think that protocol is one area that our county can be really proud of in terms of reducing the overuse of the emergency rooms in that way.
Thanks. I've got more questions, but I'll save them for another day and can follow up by email. But I'll end with just this note. I know there's been some controversy over the Restoration Center. We desperately need it. I'm preaching to the choir. We've got to work this out clearly. It's a tough issue because, but we need this yesterday. And so we'll do whatever we can to help mediate or whatever it takes, but we got to get that thing opened up as soon as possible. We have the funding for it, for goodness sake. We just got to get it going. So thank you. I'll yield back to you, Councilmember Lutke.
Thank you, and I'm going to go over to Councilmember Sales.
Thank you, Madam Lead, and thank you, Dr. Crowell, for all your work that you've been able to do throughout the pandemic, especially since most of the issues have been magnified and have been central to your leadership and our success in overcoming a lot of the barriers. So I'm glad that, I'm in this position on the better side of the pandemic where we're learning from, some past challenges, and now we're on the better side to now look at opportunities for improvement because, this is an epidemic. Throughout this weekend, I've continued to hear about mental health and the importance of having the appropriate staff. My delegate, Joe Vogel, will be introducing legislation. It's already been introduced to look at student loan repayment for social workers so that we can help bolster the capacity. And so hopefully I'll be, watching that legislation, and if support is needed, I hope that we can count on a letter of support to encourage its adoption as well. And so you mentioned the relationship with MCPS. I know that under the leadership of Chair Albornoz and Councilmember Nancy Navarro and Tom Hucker, they expanded the amount of wellness centers in MCPS and wanted to know what the relationship is, if any, is there between the MCOT program and MCPS wellness centers. Because if we're having those in, so close to the community, it would be a natural synergy for us to have these resources there.
So this is one of those moments where a roadmap of HHS would be really useful.
Yes.
Because we are so broad, the wellness centers sit in the service area that's referred to as children, youth, and families, and so we manage that piece of the work through that unit. The crisis center sits under behavioral health and crisis services, but the advantage of having an integrated system is that our chiefs talk to each other and our teams talk to each other about how they coordinate across the table with each other. So anytime there is a training opportunity that we can share with the high school wellness centers, we do that. If there's an event, the high school wellness centers know how to reach out and call for additional support from us, from the crisis center team. And if there's an emergency that requires a mobile crisis outreach team to come, they may well be the first people, along with either our school health nurses, which sit in public health. So there are a lot of different ways that the fact that we are an integrated unit means that those folks know who to call in HHS to get the resources that they need. And when they don't know, they can call their chief, and their chief will know how to make that happen.
Okay, and the $17 million that you discussed is just for the infrastructure, the building?
For the building.
That's right.
Okay, and not including the staffing capacity needs?
What we're going to do is we're going to RFP that, do a request for a proposal for a vendor who will operate the location. So the county will supply the building, and then we'll have a private operator. We'll bid it out competitively to whoever wants to take it, and they will be responsible for the staffing. Of course, we have a lot of leverage. We want to tell them the kind of people that we believe should be part of that, but they would be responsible for operating and hiring.
Okay. And I know that, this is a joint public safety and health and human services meeting. But I think what we've noticed is that we want health and human services and social workers, mental health providers to lead these efforts. And so is that part of the vision and the transition efforts to, focus more on the recruitment and the training of our mental health providers to give them the capacity to be able to handle these calls? And are we working with our police academy to look at social workers to see if they are willing to join the police academy for a specific track to look at, these sorts of specific opportunities? Or are we relying on cross-training officers?
I'm glad, I want you to, let me mention something quickly, that a little bit of an omission from all our conversation today has been the vigorous CIT training. It's a 40-hour training that this county, and I don't know many other counties across the country that have. I think it's in the report from the police department, which I also read, that they estimate about 70 to 80% of police officers right now are trained in CIT, and that includes also, I was asking, when you were asking the question earlier about cultural competence training, that also includes cultural competence training within that 40 hours. It's a week. I've had the privilege to introduce that with Chief Jones for maybe 7 or 8 times in the time that I've been here, and it's been one of the most inspiring kind of efforts that this county is doing, and we do it together, HHS and the police department, that 40-hour training. But sure.
So we are definitely looking at recruitment and retention of our staff, a more diverse staff of therapists. Speaking of the legislation that you spoke of, we internally have been reaching out to different federal, state agencies to see how we could get something internally for our clinical staff, some type of repayment of loans as an incentive to get people on board. I personally am in charge of the memorandum of understanding, and we're trying to get more. We're working with Howard University, Morgan University, I'm missing one, University of Maryland we have, and Catholic University and a couple others that we're in the process of trying to get more students and have a more robust student intern program that is more diverse, that represents our community, so that we can then train them up in the way that is best practice that we do, and then hopefully hire them on as staff. So that's one of the main pushes that we've been doing in HHS across the board to try and get counselors and therapists.
So Councilmember Sales, one of the things that I've been working on for the last 2 years is this issue. And I serve on the board. I'd served on the board of Worksession Montgomery up until tomorrow, but also I've been having conversations with Worksession Montgomery and Montgomery College. One of the challenges we face is a pipeline issue that is not endemic to Montgomery County. There's a national shortage of clinicians that are going into the graduate programs and coming out, in part because of the costs, the cost-benefit ratio. $100,000 of debt for a job that's going to pay you $60,000 a year, $70,000 a year is not exactly a winning scenario for folks. So figuring out how we get loan relief or loan repayment in exchange for public service is one of the things I think would be really useful. The other thing I would say is this, that we're on the sea change that I see for human services and mental health in particular is that we're getting to a point where, I'll say this, but not everything that is therapy isn't the only thing that's therapeutic. I've said constantly over the years to my team, and that means that we have peer recovery specialists that can be trained to do a level of the work that we may not be able to recruit for social workers to do for many years. So that's an option. I also think that when we talk about cultural competency and cultural diversity in our systems, Montgomery County is the most culturally diverse county in the state, maybe even the country. We have potentially at high school level and junior college level all the human resources we potentially need if we can create career pathways for them so that they can join us now and move from high school to college to graduate school levels while they're working in the county. And the diversity of resources is unimaginable if we can successfully do that. I don't have the answers to how we do that. I know it will take some state level, some federal level, but also some will on the part of the council and the county executive and the community to make that happen. But the partners are there and willing to do some work with us on that, I think.
Good. And just my final point as the lead, as Councilmember Albornoz mentioned, as the lead for the reduction in disparities in public health, it would be helpful to see a more comprehensive vision for wellness in our county, knowing that this has been an issue that has just been exacerbated throughout the pandemic. And given the populations that are most impacted, communities of color, limited access to care, it would be helpful to see some more attention on that. And looking forward to these discussions continuing. And, you know, as lead Lutke mentioned, you know, we're here to support and expand and build upon the successes that you've already had, and I'm just grateful for this resource and looking forward to continuing to support it. Thank you.
I just want to thank everyone today, not just those of you who spoke here on the panel and those who were here before, but all of you who've attended for listening, and to my colleagues for their thoughtful questions. This is complex work, and it requires a full collaborative team approach across the board in order to bring success that we greatly need for our county. So I appreciate that. Thank you all. And I know we will be in touch for further discussions and additional work in this area. And extra special thanks to Susan Farag for all of her hard work on this. She got her picture up on the board. But I want to thank her for her work in coordinating all of the information for my colleagues and available for this, and for her ongoing support for all that we do. So thank you. All right. With that, we are.
Thank you.
Chairs, are we adjourned?
Yes,
Do I get to
ma'am.
say that?
Yes,
All right.
ma'am.
We're adjourned.
All right.